Welcome to this continuing education course on dementia rehab and management, an evidence based update designed specifically for nurses and allied health professionals. I'm glad you're joining me for what will be a comprehensive exploration of one of the most significant healthcare challenges of our time. Alzheimer's disease and related dementias affect more than 6 million Americans currently, and projections indicate this number will double by 2050. As allied health professionals across all practice settings, you encounter individuals affected by dementia with increasing frequency. The economic burden is equally staggering, with global costs projected to reach $2 trillion annually by 2030. This underscores the urgent need for effective, evidence based rehabilitation and management strategies. The evidence base for dementia rehabilitation has evolved substantially between 2022 and 2025. This period has witnessed the publication of landmark systematic reviews and clinical practice guidelines that have refined our understanding of what works, for whom, and under what circumstances. The World Guidelines for Falls Prevention and Management for Older Adults, published in 2022, provided the first globally applicable consensus recommendations incorporating dementia-specific considerations. The American Occupational Therapy Association released updated practice guidelines in 2024, specifically addressing adults living with Alzheimer's disease and related neurocognitive disorders. The American Geriatric Society has issued comprehensive guidance on exercise interventions for older adults with cognitive impairment. Perhaps most significantly, a 2023 Global Intersocietal Delphi Consensus established standardized outcome measures across 9 domains, enabling more rigorous evaluation of intervention effectiveness. This course synthesizes the best available evidence to provide you with practical, implementable strategies for dementia rehabilitation and management. We adopt a stage-specific approach, recognizing that intervention goals, methods, and expected outcomes differ substantially across the dementia trajectory. Early-stage interventions emphasize maintaining function and independence through cognitive rehabilitation, physical exercise, and compensatory strategy training. Moderate-stage approaches shift toward managing behavioral symptoms, adapting activities, and supporting caregivers. Advanced stage care prioritizes comfort, quality of life, and palliative principles. The content reflects an interdisciplinary perspective, acknowledging that optimal dementia care requires coordinated efforts across professional boundaries. Physical therapists contribute expertise in mobility, balance, and fall prevention. Occupational therapists address functional cognition, activity adaptation, and environmental modification. Nurses provide person-centered care, behavioral symptom management, and care coordination. Together, these disciplines, along with speech-language pathologists, social workers, and others, constitute the comprehensive care team essential for addressing the complex needs of persons with dementia and their care partners. Implementation science principles inform how this course is structured, recognizing that knowledge of effective interventions is necessary but insufficient for improving patient outcomes. Barriers to implementation in long-term care, inpatient rehabilitation, and community settings are explicitly addressed, along with evidence-based strategies for overcoming them. Staff education models that produce sustained behavior change are presented, emphasizing active learning methods, theory-driven approaches, and organizational support. Upon completion of this course, you will be equipped to match exercise parameters such as frequency, duration, and session length to appropriate dementia stages. You will be able to distinguish rehabilitation approaches appropriate for early-stage dementia from those used in moderate to advanced stages. You will learn to select non-pharmacological interventions for behavioral symptoms of dementia using the DICE framework. You will recognize barriers and facilitators to implementing evidence-based dementia care interventions in care settings. You'll be able to match validated outcome measures including the MOCA, NPI, FIM motor subscale, and QOL-AD to appropriate assessment domains and dementia stages. You will identify evidence-based safety strategies for fall prevention, wandering management, and medication safety for persons with dementia. And you will recognize cultural and linguistic adaptation strategies for providing dementia care to diverse populations. The ultimate goal is improved quality of life for persons living with dementia and reduced burden for their caregivers, outcomes that the evidence increasingly demonstrates are achievable through skilled, coordinated rehabilitation and management. Let's begin with the foundations of dementia care for allied health professionals. Understanding the epidemiology and global impact of dementia provides essential context for our work. Dementia represents a syndrome characterized by progressive decline in cognitive function sufficient to interfere with independence in daily activities. Alzheimer's disease accounts for 60 to 80% of dementia cases, followed by vascular dementia, dementia with Lewy bodies, and frontotemporal dementia. The global prevalence of dementia has reached epidemic proportions, with an estimated 55 million people affected worldwide, and projections suggesting this number will triple to 152 million by 2050. The economic burden of dementia is substantial and growing. In the United States alone, the direct costs of caring for individuals with Alzheimer's disease and other dementias exceeded $355 billion in 2024, with informal caregiving contributing an additional estimated value of $346 billion annually. These costs are projected to surpass $1 trillion by 2050 if current trends continue. Beyond economic considerations, dementia profoundly affects quality of life for affected individuals and their families, contributing to caregiver burnout, depression, and adverse health outcomes among care partners. The demographic shifts driving these projections are well documented. As populations age globally, the absolute number of individuals reaching ages where dementia risk increases substantially continues to grow. However, recent research suggests that age-specific dementia incidence may be declining in some high-income countries, potentially attributable to improvements in cardiovascular risk factor management, educational attainment, and overall health. These findings offer hope that population-level prevention strategies may moderate future dementia burden, though the absolute numbers will continue to rise due to population aging. Now let's discuss dementia subtypes and their differential rehabilitation considerations. While Alzheimer's disease predominates, allied health professionals must recognize that different dementia subtypes present distinct clinical profiles with implications for rehabilitation planning. Vascular dementia, the second most common type, typically presents with a stepwise progression reflecting underlying cerebrovascular events rather than the gradual decline characteristic of Alzheimer's disease. Executive dysfunction often predominates over memory impairment in vascular dementia, and motor deficits from prior strokes may complicate physical rehabilitation. Cardiovascular risk factor management represents a meaningful intervention target, as controlling hypertension, diabetes, and other vascular risks may slow progression. Dementia with Lewy bodies presents particular challenges for rehabilitation teams. Fluctuating cognition with marked variations in alertness, attention, and function over hours to days can complicate therapy scheduling and outcome assessment. Visual hallucinations are common and may affect participation in activities. Parkinsonism, including bradykinesia, rigidity, and gait disturbance, creates fall risk and mobility limitations requiring physical therapy attention. Critically, persons with dementia with Lewy bodies demonstrate severe sensitivity to antipsychotic medications, which can precipitate life-threatening reactions. This has implications for behavioral symptom management, emphasizing the importance of non-pharmacological approaches. Frontotemporal dementia encompasses behavioral variant frontotemporal dementia and primary progressive aphasias. The behavioral variant presents with prominent personality changes, disinhibition, apathy, and loss of empathy, often with relatively preserved memory in early stages. These behavioral features create unique challenges for rehabilitation engagement and require adaptation of communication and motivational strategies. Primary progressive aphasias primarily affect language, with implications for therapy instruction delivery and assessment interpretation. Frontotemporal dementia typically affects younger individuals with onset often before age 65, creating distinct social and vocational considerations compared to late-onset Alzheimer's disease. Mixed dementia, the co-occurrence of Alzheimer's disease with vascular pathology or other dementia types, is increasingly recognized, particularly in the oldest old. Autopsy studies suggest that mixed pathology may be present in more than half of dementia cases in individuals over 80. This recognition has implications for rehabilitation, suggesting that interventions targeting multiple pathological processes, such as cognitive training for Alzheimer's pathology combined with cardiovascular management for vascular contributions, may be appropriate for many patients. Let me now introduce an important conceptual framework that guides our approach to dementia rehabilitation. The International Classification of Functioning, Disability and Health, commonly known as the ICF, provides a comprehensive framework for understanding dementia that extends beyond the traditional biomedical model focused primarily on pathology and impairment. The ICF conceptualizes functioning and disability as outcomes of interactions between health conditions and contextual factors, encompassing body functions and structures, activities, participation, environmental factors, and personal factors. For persons with dementia, the ICF framework highlights that disability results not solely from cognitive impairment, but from the interaction between impairment and the physical, social, and attitudinal environment. This perspective has profound implications for rehabilitation, shifting focus from attempting to restore lost cognitive function to optimizing functioning within the context of existing impairments. Environmental modifications, assistive technologies, caregiver training, and social support all become legitimate therapeutic targets alongside direct cognitive and physical interventions. The ICF framework also emphasizes participation, meaning involvement in life situations as the ultimate outcome of interest. Traditional clinical measures such as cognitive test scores or functional independence ratings capture important dimensions of impairment and activity limitation, but may inadequately reflect what matters most to persons with dementia and their families: continued engagement in meaningful roles and activities. This recognition has driven development of outcome measures specifically assessing quality of life and participation in dementia populations. Understanding modifiable risk factors for dementia informs rehabilitation approaches and patient education. The 2020 Lancet Commission identified 12 potentially modifiable risk factors accounting for approximately 40% of worldwide dementias. Less education, hypertension, hearing impairment, smoking, obesity, depression, physical inactivity, diabetes, low social contact, excessive alcohol consumption, traumatic brain injury, and air pollution. While rehabilitation professionals cannot modify all these factors, several fall within the scope of allied health practice. Physical inactivity represents a particularly relevant modifiable risk factor given physical therapy's expertise in exercise prescription. Observational studies demonstrate that regular physical activity is associated with reduced dementia risk, with systematic reviews suggesting risk reductions of 20 to 30% among physically active individuals. While randomized trials of exercise for dementia prevention have shown mixed results, the cardiovascular and metabolic benefits of exercise indirectly reduce dementia risk through improved vascular health. Physical therapists can incorporate dementia risk reduction messaging into exercise programming for at-risk populations. Hearing impairment has emerged as a significant modifiable risk factor, with evidence suggesting that hearing aid use may attenuate the association between hearing loss and cognitive decline. Allied health professionals should screen for hearing impairment, refer for audiological evaluation, and ensure that hearing aids are properly functioning and used during therapy sessions. Similarly, social isolation, potentially exacerbated by communication difficulties, mobility limitations, or sensory impairment, represents a risk factor that rehabilitation interventions can address through group programming, community integration, and caregiver education. The period from 2022 to 2025 has witnessed publication of several major clinical practice guidelines relevant to dementia rehabilitation. The American Occupational Therapy Association's 2024 practice guidelines for adults living with Alzheimer's disease and related neurocognitive disorders synthesize evidence for occupational therapy interventions across the disease trajectory, providing specific recommendations for reminiscence therapy, exercise, non-pharmacological behavioral interventions, cognitive therapy, sensory interventions, and caregiver education. The World Guidelines for Falls Prevention and Management for Older Adults, published in 2022, represent a landmark achievement in global consensus building. Developed through a modified Delphi process involving 96 experts from 39 countries, these guidelines provide 96 recommendations addressing falls risk assessment, multifactorial interventions, exercise programs, medication review, environmental modification, and population-specific considerations including cognitive impairment. The American Geriatric Society subsequently issued a response document contextualizing these global recommendations for United States practice and addressing implementation considerations specific to American healthcare delivery systems. The Centers for Medicare and Medicaid Services Guiding an Improved Dementia Experience Model, known as the GUIDE model, initiated in 2024, represents a significant policy development supporting comprehensive dementia care. This demonstration project tests whether structured care coordination, caregiver support services, and respite care can improve outcomes while reducing costs for Medicare beneficiaries with dementia. While outcome data are still emerging, the GUIDE model has catalyzed attention to care coordination and caregiver support as essential components of dementia care rather than optional additions. The Fifth Canadian Consensus Conference on the Diagnosis and Treatment of Dementia issued updated recommendations in 2022 addressing risk reduction, screening and diagnosis, deprescribing, and non-pharmacological interventions. These guidelines emphasize the importance of multi-component lifestyle interventions for dementia risk reduction and provide specific guidance on deprescribing potentially inappropriate medications in persons with dementia. Now let's discuss stage-specific care principles, which provide a useful framework for matching interventions to patient needs and capacities. While various staging systems exist, a three-stage model distinguishing early or mild, moderate, and advanced or severe dementia offers practical utility for rehabilitation planning. Early-stage dementia is characterized by memory impairment that interferes with complex instrumental activities of daily living such as financial management, medication administration, and meal preparation, while basic self-care activities remain largely intact. Individuals typically retain awareness of their deficits, may experience frustration or depression in response to declining abilities, and can participate meaningfully in rehabilitation planning. Intervention goals in this stage emphasize maintaining independence as long as possible through cognitive rehabilitation, compensatory strategy training, physical exercise to preserve mobility and cardiovascular health, advanced care planning, and caregiver education. Moderate stage dementia involves progressive impairment in basic activities of daily living, including bathing, dressing, and toileting, with increasing need for supervision and assistance. Behavioral and psychological symptoms of dementia, commonly referred to as BPSD, including agitation, aggression, wandering, sleep disturbance, and psychosis, commonly emerge or intensify during this stage, often driving caregiver burden and institutional placement decisions. Intervention goals shift toward managing behavioral symptoms through non-pharmacological approaches, adapting activities to preserved abilities, supporting caregiver coping, and ensuring safety. Advanced stage dementia involves profound cognitive impairment with minimal verbal communication, complete dependence in activities of daily living, and often motor impairments including dysphagia, incontinence, and immobility. Intervention goals in this stage prioritize comfort, quality of life, and palliative principles. Active rehabilitation may have limited applicability, though sensory stimulation, positioning, and gentle movement can contribute to comfort and prevent complications. Goals of care discussions with families become paramount as decisions regarding hospitalization, artificial nutrition, and other intensive interventions arise. Before we continue, let me address evidence hierarchy and clinical decision-making. Allied health professionals must be skilled consumers of research evidence to provide optimal dementia care. The evidence hierarchy, familiar from evidence-based practice frameworks, ranging from systematic reviews and meta-analyses at the apex, through randomized controlled trials, cohort studies, case series, and expert opinion, provides guidance for weighting different sources of evidence. However, applying evidence hierarchies in dementia rehabilitation requires recognition of several complicating factors. First, the heterogeneity of dementia populations, varying by etiology, severity, comorbidities, and care setting, limits generalizability of findings from any single study. Meta-analyses pooling diverse populations may obscure important subgroup differences. Second, many dementia rehabilitation interventions involve complex, multi-component approaches that are difficult to standardize and replicate across settings. Third, outcomes valued by persons with dementia and families such as quality of life, meaningful engagement, and caregiver well-being may differ from outcomes traditionally prioritized in clinical trials. Despite these challenges, the dementia rehabilitation evidence base has matured substantially. Network meta-analyses now permit comparison of multiple interventions simultaneously, identifying which approaches demonstrate greatest effectiveness for specific outcomes. Implementation science frameworks guide translation of research findings into routine practice. Patient-reported outcome measures increasingly supplement clinician-administered assessments. Together, these advances support more confident clinical decision-making while acknowledging persistent uncertainties. Now let's move into the second major section of our course, focusing on physical therapy interventions across the dementia continuum. Physical therapy plays an essential role in dementia care across all disease stages, though intervention goals, methods, and expected outcomes evolve as the disease progresses. The evidence base for physical therapy interventions in dementia has expanded substantially, with multiple systematic reviews and meta-analyses published between 2022 and 2025, providing guidance for clinical practice. A key finding from this literature is that physical exercise represents one of the most effective non-pharmacological interventions available for persons with dementia, with benefits extending beyond physical function to include cognitive outcomes, behavioral symptoms, and quality of life. Recent network meta-analyses have compared multiple intervention types simultaneously, enabling more nuanced recommendations regarding optimal exercise parameters. Physical cognitive rehabilitation combining motor and cognitive training has emerged as the most effective non-pharmacological intervention for cognitive outcomes in persons with dementia. Multi-component exercise programs incorporating aerobic, resistance, and balance training demonstrate superior outcomes compared to single-modality approaches. These findings support the value of comprehensive physical therapy programs rather than isolated exercise prescriptions. For early-stage dementia, physical therapy emphasizes maintaining and optimizing physical function to support continued independence in daily activities. Persons in this stage typically retain sufficient cognitive capacity to learn new motor skills, follow complex exercise instructions, and participate in goal setting for rehabilitation. The evidence strongly supports multi-component exercise programs combining aerobic training, resistance exercise, and balance activities. Optimal exercise parameters for early-stage dementia have been investigated across multiple systematic reviews. Evidence suggests that programs involving 2 to 3 sessions per week, approximately 60 minutes per session, and fewer than 30 total sessions demonstrate the largest effect sizes for cognitive outcomes. However, these parameters should be individualized based on baseline fitness, comorbidities, and patient preferences. Aerobic exercise, defined as sustained activity elevating heart rate to 60 to 80% of maximum, has demonstrated particular benefits for cognitive function, potentially through mechanisms involving cerebral blood flow, neuroplasticity, and reduction of cardiovascular risk factors. Dual task training, which involves performing cognitive and motor tasks simultaneously, has gained attention as a targeted intervention for fall prevention in persons with cognitive impairment. Persons with dementia demonstrate particular difficulty with dual task performance, which contributes to fall risk during everyday activities that inherently involve concurrent cognitive and motor demands. Systematic reviews support the efficacy of dual task training for improving both cognitive and motor outcomes, though optimal protocols remain under investigation. Physical cognitive rehabilitation represents an emerging approach that systematically integrates motor and cognitive training within a unified intervention framework. A 2024 network meta-analysis identified physical cognitive rehabilitation as the most effective non-pharmacological intervention for cognitive outcomes in dementia, surpassing either physical or cognitive training alone. This finding has important implications for physical therapy practice, suggesting that therapists should incorporate cognitive demands into exercise programming rather than treating physical and cognitive domains separately. Comprehensive gait and balance assessment forms the foundation for fall prevention programming in persons with dementia. Standard assessment tools require consideration of cognitive demands and potential modifications for use in dementia populations. The timed up and go test, measuring time to rise from a chair, walk 3 meters, turn, return, and sit, provides a quick functional mobility screen with established predictive validity for falls. Normative values suggest that times exceeding 12 to 14 seconds indicate increased fall risk, though cognitive impairment itself slows timed up and go performance independent of physical factors. The Berg Balance Scale provides more detailed assessment of static and dynamic balance through 14 items scored 0 to 4, with a maximum score of 56. Scores below 45 indicate increased fall risk. A 2024 meta-analysis of virtual reality interventions found significant improvements in Berg Balance Scale scores following VR-based rehabilitation, demonstrating the measure's sensitivity to intervention effects in dementia populations. However, Berg Balance Scale administration requires approximately 15 to 20 minutes and sufficient cognitive capacity to follow multi-step instructions, potentially limiting utility in moderate to advanced dementia. The short physical performance battery combines balance testing, gait speed, and chair stand performance in a composite measure with range of 0 to 12 and strong predictive validity for disability, hospitalization, and mortality. Gait speed alone, measured over 4 to 6 meters at usual pace, provides a simple yet powerful indicator of overall health status and fall risk. Speeds below 0. 8 meters per second indicate increased fall risk and mobility limitation. The cognitive timed up and go, which adds a cognitive task such as counting backwards to standard timed up and go, assesses dual task capacity and may be more sensitive to fall risk than single task assessments. Assessment should extend beyond standardized measures to include observation of gait quality, compensatory strategies, and environmental interaction. Features suggesting increased fall risk include reduced step length, increased step width, shuffling pattern, festination, reduced arm swing, difficulty with turns, and hesitation at thresholds or transitions. Video recording of gait, when feasible, enables detailed analysis and documentation of change over time. Environmental assessment, ideally conducted in the home setting for community-dwelling individuals, identifies specific hazards and informs modification recommendations. As dementia progresses to the moderate stage, physical therapy approaches require adaptation to accommodate declining cognitive capacity while continuing to address physical function and safety. Persons in this stage may have difficulty following complex multi-step instructions, retaining new information between sessions, or maintaining attention during extended exercise bouts. However, procedural memory, the implicit memory system supporting learned motor skills, often remains relatively preserved, enabling continued benefit from physical activity even as declarative memory deteriorates. Exercise prescription for moderate stage dementia typically involves shorter, more frequent sessions compared to early stage programming. A 2024 meta analysis examining physical exercise effects on activities of daily living in Alzheimer's disease found that programs involving 4 to 5 sessions per week with sessions lasting 30 minutes or less demonstrated the largest effect sizes. This finding suggests that breaking exercise into smaller, more manageable doses may optimize outcomes for persons with moderate dementia who cannot sustain attention or effort for extended periods. Resistance training and aerobic exercise both remain appropriate for moderate stage dementia, though resistance training may offer particular advantages given its potential for maintaining strength needed for transfers and mobility. The same meta-analysis found that resistance training combined with aerobic exercise demonstrated superior outcomes compared to either modality alone. Group exercise formats can provide social stimulation and peer modeling that supports engagement, though individual supervision may be necessary for persons with behavioral symptoms or safety concerns. Therapeutic exercise in long-term care settings for residents with moderate dementia requires attention to the unique contextual factors of these environments. A systematic review examining exercise interventions in long-term care found that programs involving 3 or more sessions weekly produce significant improvements in both ADL function and cognitive status. Group exercise formats demonstrated particular effectiveness for cognitive outcomes in these settings, potentially reflecting the additional benefits of social engagement inherent in group programs. Safe and effective exercise prescription for persons with dementia requires attention to several unique considerations beyond standard geriatric exercise guidelines. Cognitive impairment affects ability to report symptoms, recognize exertion limits, and respond appropriately to warning signs. Therapists must rely more heavily on objective monitoring and clinical observation than patient self-report. Cardiovascular monitoring during aerobic exercise should include heart rate and blood pressure assessment, with recognition that persons with dementia may not perceive or report symptoms of overexertion. The rate of perceived exertion scale can be simplified for dementia populations using facial expression charts or 3-level scales of easy, moderate, and hard rather than the standard 6 to 20 or 0 to 10 formats. Observation of breathing pattern, facial expression, and movement quality provides additional indicators of exercise intensity and tolerance. A systematic review examining safety and efficacy of physiotherapy in dementia noted over 1,000 adverse events reported across included studies. While this may appear concerning, it reflects the comprehensive reporting in well-designed trials rather than suggesting that exercise is inherently dangerous. Most adverse events were minor, such as muscle soreness and fatigue, though falls during exercise sessions and cardiovascular events occurred rarely. These findings underscore the importance of appropriate supervision, individualized prescription, and systematic monitoring rather than avoidance of exercise altogether. Medication effects require consideration in exercise prescription. Many persons with dementia take medications affecting cardiovascular response, balance, or blood glucose. Beta blockers attenuate heart rate response to exercise, requiring use of alternative intensity monitoring methods. Orthostatic hypotension, common with many dementia medications, necessitates careful transitions between positions. For persons with diabetes, exercise timing relative to meals and medications prevents hypoglycemia. Physical therapy for advanced stage dementia shifts focus from functional improvement to comfort, quality of life, and prevention of complications associated with immobility. Persons in this stage typically have profound cognitive impairment, limiting their ability to follow instructions or participate actively in exercise. However, physical therapy interventions including positioning, passive range of motion, and gentle assisted movement can contribute to comfort and prevent contractures, pressure injuries, and deconditioning. The evidence base for rehabilitation in advanced dementia is limited compared to earlier stages, reflecting both the challenges of conducting research in this population and questions about the appropriateness of active rehabilitation when life expectancy is limited. A systematic review of post-acute care rehabilitation for persons with dementia found that individuals with advanced disease demonstrated lower likelihood of returning home and less functional improvement compared to those without cognitive impairment. However, this does not necessarily indicate that rehabilitation is futile. Rather, goals and expectations should be calibrated appropriately. Safety monitoring becomes paramount in advanced dementia, as these individuals cannot reliably report pain, discomfort, or adverse symptoms. Low intensity activities with close supervision are appropriate. High intensity training or activities with significant fall risk are generally not indicated for this population. Falls represent a major source of morbidity and mortality in persons with dementia, who experience fall rates 2 to 3 times higher than cognitively intact older adults. The World Guidelines for Falls Prevention and Management for Older Adults provide comprehensive recommendations applicable to persons with dementia, emphasizing multifaceted approaches combining exercise, environmental modification, medication review, and vision optimization. Exercise programs for fall prevention in dementia should include balance training as a core component, ideally combined with strength training and functional activities. The World Guidelines recommend exercise as part of multi-domain interventions for care home residents, acknowledging that standalone exercise programs have shown inconsistent effects in institutional settings where multiple risk factors converge. Tai Chi and similar mind-body exercises have demonstrated promise for fall prevention in community-dwelling older adults, though evidence specific to dementia populations is more limited. Environmental modification for fall prevention includes removal of trip hazards, improvement of lighting, installation of grab bars and handrails, and use of non-slip flooring. For persons with dementia, additional considerations include minimizing confusing or overstimulating visual environments, ensuring adequate contrast between surfaces, and addressing wandering-related fall risks through appropriate supervision and environmental design. Physical restraints are explicitly discouraged in the World Guidelines due to evidence of increased injury risk and adverse psychological effects. Medication review represents an essential component of fall prevention, often requiring interprofessional collaboration. Polypharmacy is common in older adults with dementia, and many commonly prescribed medications, including psychotropics, antihypertensives, and sedative hypnotics, increase fall risk. Physical therapists should advocate for medication review when patients present with recurrent falls, new onset balance impairment, or orthostatic symptoms, facilitating communication with prescribing providers. The American Geriatric Society's response to the World Falls Guidelines emphasizes implementation considerations for United States practice, including the importance of fall risk screening, individualized intervention planning, and attention to healthcare system factors that may impede guideline concordant care. Integration of fall prevention into routine dementia care rather than addressing falls only after they occur represents a key recommendation with implications for physical therapy practice across settings. Virtual reality and other technology-assisted rehabilitation approaches have emerged as promising adjuncts to traditional physical therapy for persons with dementia. A 2024 systematic review and meta-analysis found that VR-based interventions produced significant improvements in cognition, memory, and balance compared to conventional interventions. Optimal parameters included 5 to 8 weeks duration, at least 3 sessions weekly, and session lengths exceeding 30 minutes. Immersive VR, involving head-mounted displays that fully replace the visual environment, demonstrated larger effect sizes compared to non-immersive approaches using standard monitors or projection screens. However, immersive VR may not be tolerable for all persons with dementia, and concerns regarding cybersickness, disorientation, and anxiety require careful patient selection and monitoring. Semi-immersive systems using commercial gaming platforms offer a middle ground with established safety profiles and lower equipment costs. Mobile device-based interventions have also demonstrated promise, with One Network meta-analysis identifying mobile games as most effective for global cognition and executive function among digital intervention types. These findings suggest potential for home-based, technology-assisted exercise programming that could extend the reach of physical therapy services, though implementation challenges including device operation, internet access, and caregiver support must be addressed. Now let's transition to occupational therapy approaches by disease stage. Occupational therapy addresses the functional cognition impairments that characterize dementia, the altered perception, thoughts, mood, and behavior that affect functional performance and meaningful engagement in occupations. The American Occupational Therapy Association's 2024 practice guidelines provide evidence-based recommendations specifically addressing adults living with Alzheimer's disease and related neurocognitive disorders, synthesizing findings from 12 systematic reviews published between 2018 and 2021. These guidelines establish occupational therapy as an essential component of comprehensive dementia care, with interventions spanning the disease trajectory from early diagnosis through advanced stages. The occupational therapy approach to dementia emphasizes person centered, occupation based intervention that considers the unique interests, values, roles, and contexts of each individual. Rather than focusing solely on cognitive deficits, occupational therapists analyze the interaction between person, environment, and occupation to identify barriers to participation and design interventions that optimize function within the context of existing impairments. This ecological perspective aligns with the International Classification of Functioning framework and supports quality of life outcomes that matter to persons with dementia and their families. Occupational therapy for early stage dementia emphasizes cognitive oriented interventions that maintain or improve functional cognition, while individuals retain capacity to learn compensatory strategies. The AOTA practice guidelines provide strong evidence supporting cognitive therapy approaches, including remediation through direct training of cognitive skills, compensation through teaching strategies to work around deficits, and memory training techniques such as errorless learning. Errorless learning represents a particularly relevant technique for dementia populations. This approach minimizes errors during skill acquisition by providing high levels of support and cueing, gradually fading assistance as skills become established. The theoretical rationale is that persons with impaired explicit memory cannot effectively learn from trial and error processes that rely on conscious recollection of previous attempts. By preventing errors from occurring, errorless learning capitalizes on preserved implicit memory systems. Applications include teaching compensatory strategies for instrumental activities, smartphone and technology use, and procedural tasks important for maintaining independence. Systematic reviews indicate that cognitive-oriented interventions demonstrate larger effect sizes when delivered over longer durations of more than 2 months, involving more than 10 encounters, and provided in individual rather than group formats. These findings have important implications for service delivery, suggesting that brief intervention episodes may be insufficient to achieve meaningful outcomes. Additionally, persons with higher baseline cognitive function and, interestingly, less formal education appear to benefit more from occupational therapy interventions, possibly reflecting greater cognitive reserve or capacity for new learning. Computerized cognitive training and game-based digital interventions have emerged as scalable approaches for early-stage dementia. A 2025 network meta-analysis found that mobile device-based games demonstrated the largest effect sizes for global cognition among digital intervention types. These technologies offer potential for home-based practice between therapy sessions, though therapist guidance in selecting appropriate applications and ensuring correct use remains important. Dual task training combining cognitive and motor demands such as walking while performing cognitive tasks represents another evidence-based approach with particular relevance for fall prevention. Activity analysis, the systematic examination of an activity's component demands, represents a core occupational therapy skill with particular relevance to dementia care. By understanding the cognitive, motor, sensory, and social demands of activities important to clients, occupational therapists can identify specific barriers to performance and design targeted interventions. For persons with dementia, cognitive demands, including attention, sequencing, problem solving, and memory, typically present the greatest challenges, though motor and sensory factors may also contribute. Activity adaptation modifies task demands to match preserved abilities while maintaining the essential meaning and purpose of the activity. Adaptations may involve simplifying the activity by reducing the number of steps or choices, modifying the environment to provide additional cues and support, changing the timing or duration of activity engagement, or altering the social context through increased assistance or supervision. The goal is enabling continued participation in valued activities rather than abandonment as abilities decline. Consider the example of meal preparation, often one of the first complex instrumental activities of daily living affected by dementia. Activity analysis reveals demands including planning and sequencing, such as deciding what to prepare, gathering ingredients and following recipe steps, attention and concentration, such as monitoring multiple elements simultaneously, safety awareness, such as managing heat sources and sharp utensils, and motor coordination, such as cutting, stirring, and handling containers. Adaptations might include using familiar, well-rehearsed recipes, pre-gathering ingredients, using simplified one-pot meals, providing step-by-step visual cues, removing or securing hazardous items, and increasing supervision during cooking. Grading activities along a continuum of complexity enables therapists to match demands to current abilities while planning for future decline. Early-stage clients might prepare complete meals with minimal adaptation, Moderate stage individuals might participate in specific steps like stirring or setting table, while caregivers manage complex or hazardous elements. Advanced stage persons might engage through sensory experience, such as smelling familiar foods or handling utensils without active preparation. This grading maintains meaningful connection to valued activities across the disease trajectory. As dementia progresses to the moderate stage, occupational therapy approaches shift emphasis from cognitive rehabilitation to sensory based interventions, environmental modification, and behavioral symptom management. The AOTA practice guidelines provide moderate to strong evidence for reminiscence therapy, exercise, non pharmacological behavioral interventions, and sensory interventions in this population. Reminiscence therapy involves the discussion of past activities, events, and experiences, typically using prompts such as photographs, music, or familiar objects from the person's life history. A 2025 systematic review and meta analysis found that reminiscence therapy produces moderate effects on depressive symptoms in persons with dementia. The intervention capitalizes on the relative preservation of remote memories compared to recent memories in Alzheimer's disease, enabling meaningful engagement and communication even as the disease progresses. Implementation may involve individual sessions, group formats, or caregiver delivered interventions in home settings. Sensory stimulation interventions address the sensory processing changes that commonly accompany dementia progression. Approaches include massage and touch therapy, aromatherapy, music interventions, and multisensory stimulation environments known as snoozlin. The evidence base varies across modalities, with massage and reflexology demonstrating moderate effects on pain reduction when provided 1 to 7 times weekly for durations ranging from 10 to 120 minutes across 4 to 20 weeks. Music-based interventions have received particular attention, with systematic reviews supporting effects on mood, agitation, and social engagement. The DICE approach, which stands for Describe, Investigate, Create, Evaluate, provides a structured framework for addressing behavioral and psychological symptoms of dementia that commonly emerge during the moderate stage. Originally developed for physician and caregiver use, DICE has been adopted across disciplines including occupational therapy. The approach involves describing the behavior in specific, objective terms, investigating underlying causes including unmet needs, environmental triggers, and medical factors, creating and implementing an intervention plan, and evaluating response and modifying as needed. This systematic approach prevents reflexive attribution of behaviors to dementia and ensures that potentially modifiable factors are addressed. Environmental modification represents a core occupational therapy intervention with applications across all dementia stages. The rationale is straightforward. If the environment can be modified to compensate for cognitive deficits, functional independence can be maintained despite underlying impairment. Environmental interventions range from simple adaptations such as labeling and cueing to comprehensive redesign of living spaces. For early-stage dementia, environmental modifications focus on compensatory strategies that support memory and organization. Examples include medication management systems with alarms and reminders, calendar and scheduling systems prominently displayed, labeled storage to support finding items, and simplified routines that reduce cognitive demands. Technology-based environmental modifications, including smart home systems, automated lighting, and motion sensors, show promise for extending independence, though evidence specific to dementia populations requires further development. Moderate-stage environmental modifications increasingly emphasize safety and behavioral management. Strategies include securing exits to prevent elopement, removing or securing hazardous items, improving lighting to reduce confusion and falls, reducing clutter and overstimulation, and creating clearly defined spaces for different activities. Home-like, personalized environments have demonstrated benefits for reducing agitation and improving quality of life in residential care settings compared to institutional designs. Advanced-stage environmental modifications prioritize comfort and sensory experience. Multisensory environments providing controlled visual, auditory, tactile, and olfactory stimulation can reduce agitation and promote relaxation. Attention to seating and positioning supports comfort and prevents complications of immobility. Family photographs and personal items maintain connection to identity even when cognitive recognition is impaired. The AOTA practice guidelines identify care partner education and training as a strongly evidence-supported intervention for dementia care. Caregivers, whether family members or professional care staff, spend far more time with persons with dementia than therapists can. Therefore, equipping caregivers with knowledge and skills multiplies the impact of occupational therapy intervention. Effective caregiver education programs share several characteristics identified in systematic reviews. Content should be tailored to caregiver needs and delivered using active, skill building approaches rather than passive didactic formats. Training and communication techniques, including validation approaches, distraction and redirection, and management of specific behavioral symptoms, demonstrates particular value. Programs addressing caregiver self care and stress management reduce burden and depression, indirectly benefiting care quality. The Tailored Activity Program, known as TAP, exemplifies evidence-based caregiver intervention. TAP trains caregivers to design activities matched to the interests and abilities of persons with dementia, providing occupation-based engagement that reduces behavioral symptoms while offering caregivers concrete skills for daily management. Randomized controlled trials have demonstrated TAP effectiveness for reducing behavioral symptoms and caregiver burden, with cost analyses suggesting cost neutrality or savings compared to usual care. Robotic interventions, particularly companion robots such as PARO, a therapeutic seal robot, have gained attention as adjunctive approaches for persons with dementia. A 2025 systematic review and meta-analysis found that intelligent robot interventions significantly reduced agitation and anxiety while increasing social interaction. However, the same review found no significant effects on cognition, overall neuropsychiatric symptoms, depression, apathy, or quality of life. These findings suggest that robotic interventions may serve specific purposes, particularly reducing negative emotions and promoting engagement, without providing broader therapeutic benefits. Limitations including high cost, technical challenges, and questions about long-term engagement temper enthusiasm for widespread implementation. Occupational therapists can assess appropriateness for individual clients, introduce robots within therapeutic contexts, and train caregivers in effective use. Now let's explore nursing best practices and person-centered care in detail. Person-centered care represents the foundational philosophy underlying contemporary dementia nursing practice. This approach, pioneered by Tom Kitwood and further developed through international consensus, recognizes persons with dementia as unique individuals with continuing personhood rather than as patients defined primarily by their diagnosis and deficits. Person-centered care emphasizes understanding each individual's life history, preferences, values, and needs, treating all behaviors as meaningful communication, supporting remaining abilities while providing assistance with areas of difficulty, and creating relationships of trust and respect. The evidence base for person-centered care in dementia has matured substantially. A 2024 systematic review and meta-analysis examining person-centered care delivery in residential aged care found consistent positive effects on quality of life and behavioral symptoms when person-centered approaches were consistently implemented. However, the same review identified substantial implementation challenges, with many facilities struggling to translate person-centered principles into consistent practice. Organizational culture, staff education, and leadership support emerged as critical determinants of successful implementation. Implementation of person-centered care requires both individual competencies and organizational support. At the individual level, nurses need skills in biographical assessment, validation communication, and flexible care planning that adapts to changing needs and preferences. At the organizational level, person-centered care requires adequate staffing, time for relationship-building activities, physical environments that support autonomy and engagement, and management practices that reinforce person-centered values. Without organizational support, individual nurses cannot sustain person-centered practice amid competing demands. Effective communication with persons with dementia requires adaptation of standard approaches to accommodate cognitive impairments affecting language comprehension, expression, attention, and memory. Nurses spend more time in direct communication with persons with dementia than perhaps any other professional group, making communication skills essential to nursing practice. Verbal communication adaptations include speaking slowly and clearly, using simple sentences with one idea per statement, allowing adequate time for processing and response, avoiding open-ended questions that may overwhelm cognitive capacity, offering limited choices rather than unlimited options, and repeating or rephrasing as needed without conveying frustration. Concrete, specific language typically works better than abstract concepts. Present-focused communication avoids reliance on impaired recent memory. Rather than asking what someone had for breakfast, the nurse might observe that they see the person is finishing their eggs. Nonverbal communication assumes increasing importance as verbal abilities decline. Facial expression, tone of voice, body posture, touch, and physical proximity all convey meaning that persons with dementia may perceive even when words are not understood. Approaching from the front, making eye contact before speaking, using a calm and reassuring tone, and offering gentle touch when culturally appropriate and welcomed by the individual support effective communication. Rushed or tense nonverbal cues may trigger anxiety or resistance even when verbal content is appropriate. Validation approaches, developed by Naomi Feil, represent a communication philosophy particularly relevant to moderate and advanced dementia. Rather than correcting misperceptions or orienting to external reality, validation acknowledges the emotional truth of the person's experience. If a resident asks to see her deceased mother, the validating response explores the underlying feeling, asking about missing her mother and inviting the person to share memories, rather than confronting the factual error. This approach reduces distress and maintains connection when reality orientation would cause repeated grief or agitation. Nursing care for early-stage dementia emphasizes health promotion, advanced care planning, and support for continued independence. Persons in this stage typically live in community settings with family caregiver support and may be encountering formal healthcare services primarily for diagnosis and early management rather than daily care. Nurses in primary care, specialty clinics, and community health settings have opportunities to establish relationships that will support care throughout the disease trajectory. Cognitive stimulation through social engagement, mental activities, and structured programs represents an evidence-supported nursing intervention for early-stage dementia. The mechanism of action likely involves maintaining cognitive reserve and potentially slowing disease progression, though evidence for disease modification remains limited. Nurses can provide education about cognitively stimulating activities, connect patients with community programs, and reinforce the importance of continued engagement in meaningful occupations. Physical activity promotion is equally important, given the strong evidence for exercise benefits in dementia. Nurses can assess current activity levels, provide individualized recommendations considering comorbidities and preferences, address barriers to physical activity, and monitor progress over time. Coordination with physical therapy for exercise prescription and supervision may be appropriate for persons with mobility limitations or complex medical conditions. Advanced care planning represents an essential but often neglected aspect of early-stage dementia care. While persons retain decision-making capacity, they can articulate values and preferences that will guide future care when capacity is diminished. Nurses play a crucial role in initiating advanced care planning conversations, documenting goals of care, and ensuring that completed advanced directives are accessible when needed. Culturally sensitive approaches recognize that advanced care planning practices vary across cultures and should be adapted accordingly. Nutritional challenges are common in dementia and worsen as the disease progresses. Early-stage difficulties may include forgetting to eat, losing interest in food preparation, making poor food choices, or experiencing changes in taste and smell that affect appetite. Moderate-stage problems include forgetting to chew or swallow, eating non-food items, which is called pica, and difficulty using utensils. Advanced dementia often involves dysphagia with aspiration risk, refusal of food, and questions about artificial nutrition. Nursing interventions for nutritional support vary by stage. Early-stage strategies include meal planning assistance, simplified preparation methods, regular meal schedules, and monitoring of weight and nutritional status. Moderate-stage interventions involve cueing and prompting during meals, finger foods that reduce utensil demands, modified textures as swallowing difficulties emerge, and environmental modifications such as reduced distractions and appropriate lighting. Social dining, eating with others rather than alone, may improve intake through modeling and engagement. Hydration deserves particular attention, as persons with dementia often have reduced thirst perception and may forget to drink. Dehydration contributes to confusion, constipation, urinary tract infections, and falls. Nursing strategies include offering fluids frequently throughout the day, providing preferred beverages, using cups and containers that are easy to handle, and monitoring for signs of dehydration including concentrated urine, dry mucous membranes, and orthostatic changes. In advanced dementia, decisions about artificial nutrition and tube feeding arise when oral intake becomes inadequate or unsafe. Evidence does not support tube feeding for improving survival, preventing aspiration pneumonia, or enhancing quality of life in advanced dementia. Current recommendations favor careful hand feeding, with acceptance that reduced intake is a natural part of the dying process. Nurses facilitate family understanding of these complex decisions, ensuring that choices align with patient values and documented preferences. Behavioral and psychological symptoms of dementia emerge as a major focus of nursing care during the moderate stage. These symptoms encompass a heterogeneous group including agitation, aggression, wandering, sleep disturbance, psychosis with hallucinations and delusions, depression, anxiety, and apathy. These symptoms affect more than 90% of persons with dementia at some point in the disease course, cause significant distress for individuals and caregivers, and frequently precipitate nursing home admission. Non pharmacological interventions represent the recommended first line treatment for behavioral symptoms, reserving pharmacological approaches for severe or refractory symptoms or situations where non pharmacological management is not feasible. This recommendation reflects both the limited efficacy and significant adverse effects of psychotropic medications in dementia populations. A comprehensive review in the American Journal of Psychiatry found that available evidence indicates several non pharmacological interventions are beneficial and recommended as first line treatments. The DICE approach provides a structured framework for addressing behavioral symptoms that prevents reflexive use of medications and ensures systematic consideration of modifiable factors. The described step involves characterizing the behavior in specific, observable terms, noting what happens, when, where, how often, and what the immediate antecedents and consequences are. The investigate step explores underlying causes, including physical factors such as pain, infection, constipation, and medication effects, psychological needs such as boredom, loneliness, and fear, environmental triggers such as overstimulation, understimulation, and unfamiliar settings, and caregiver factors such as communication style and approach to care. The create step involves developing and implementing an intervention plan targeting identified factors. The evaluate step assesses response and guides modification as needed. An umbrella review of symptom-specific non-pharmacological interventions found that massage and touch therapy ranked highest for reducing agitation, with music therapy demonstrating effectiveness across multiple symptom domains including agitation, depression, and anxiety. Personally tailored interventions designed specifically for individual patients based on their histories, preferences, and identified triggers demonstrated greater effectiveness than standardized protocols applied uniformly. These findings reinforce the importance of individualized assessment and intervention planning. Sleep disturbances affect up to 70% of persons with dementia and create significant burden for caregivers who must manage nighttime wakefulness, wandering, and reversed sleep-wake cycles. The pathophysiology involves degeneration of brain regions regulating circadian rhythms, compounded by reduced exposure to light and physical activity that normally entrains sleep-wake cycles. Medications commonly used in dementia, including cholinesterase inhibitors and some antidepressants, may also affect sleep. Non-pharmacological sleep interventions focus on sleep hygiene and circadian rhythm regulation. Light exposure during daytime hours, ideally bright natural light in the morning, helps maintain circadian entrainment. Physical activity during the day promotes nighttime sleep, though exercise should be completed several hours before bedtime. Limiting caffeine and alcohol, maintaining consistent sleep and wake times, and creating a comfortable sleep environment support sleep quality. Daytime napping, if necessary, should be limited in duration and timing to avoid interfering with nighttime sleep. Evening and bedtime routines can reduce sundowning, the increasing confusion and agitation that commonly occurs in late afternoon and evening. Calming activities, reduced stimulation, comfortable lighting that is neither too bright nor too dark, and familiar bedtime rituals may ease the transition to sleep. For persons who do wake at night, ensuring safety is paramount. Low lighting, secured exits, and clear pathways reduce fall and elopement risk during nighttime wandering. Pharmacological approaches to sleep disturbance carry significant risks in dementia populations. Benzodiazepines and other sedative hypnotics increase fall risk, may cause paradoxical agitation, and provide little evidence of benefit. Melatonin shows modest evidence of efficacy with a favorable safety profile, though effects are inconsistent. Antipsychotics are sometimes used for nighttime agitation but carry black box warnings for increased mortality in dementia and should be reserved for severe symptoms unresponsive to non-pharmacological approaches. Nursing care for advanced dementia shifts focus toward comfort, quality of life, and palliative principles. The advanced study, examining care practices across nursing homes, found substantial variation in care intensity for residents with advanced dementia, with organizational culture significantly influencing treatment decisions. Facilities with more person-centered cultures provided less aggressive interventions while maintaining or improving quality of life. Comfort-focused care involves proactive attention to potential sources of discomfort, including pain, hunger, thirst, positioning, temperature, and emotional distress. Because persons with advanced dementia cannot reliably report symptoms, nurses must rely on behavioral observation and knowledge of individual baselines to detect changes suggesting discomfort. Assessment tools designed for nonverbal patients can support systematic evaluation, though clinical judgment remains essential. Decisions regarding potentially burdensome interventions, including hospitalization, artificial nutrition, antibiotics, and emergency department transfers, frequently arise during advanced dementia. Evidence increasingly suggests that comfort focused approaches avoiding aggressive interventions produce outcomes comparable to or better than intensive treatment for many conditions common in advanced dementia. Nurses advocate for care aligned with documented goals, facilitate family understanding of prognosis and options, and ensure that comfort measures are consistently provided. Hospitalization poses significant risks for persons with dementia, including delirium, functional decline, falls, and adverse medication effects. The dementia care pointers published in Age and Aging in 2022 provide evidence based guidance for improving hospital care for persons with dementia. These recommendations emphasize early identification and documentation of cognitive impairment, person centered communication, involvement of families as care partners, environmental modifications reducing confusion, and attention to delirium prevention. Delirium superimposed on dementia represents a particularly challenging clinical scenario. Persons with pre-existing dementia are at markedly elevated risk for hospital-acquired delirium, which further impairs cognition, prolongs hospitalization, increases mortality risk, and may accelerate subsequent dementia progression. Recognition of delirium in persons with pre-existing dementia requires comparison to baseline function rather than reliance on standardized cutoffs, as screening tools may not detect change from an already impaired baseline. Nurse-initiated protocols for managing behavioral changes in hospitalized patients with dementia have been developed and tested. A modified E-Delphi study published in 2025 established consensus on a multi-component framework integrating assessment, communication strategies, environmental modification, and escalation pathways. Such protocols support consistent, evidence-based care while recognizing that nurse-initiated interventions cannot address all situations requiring medical evaluation or treatment. Let's now move to our fifth module, addressing interdisciplinary integration, implementation science, and staff education. Comprehensive dementia care requires coordinated efforts across multiple disciplines, with no single profession possessing all the expertise needed to address the complex, evolving needs of persons with dementia and their families. Effective interdisciplinary collaboration involves shared goals, clear communication, mutual respect for professional roles, and mechanisms for care coordination. While the evidence base for interdisciplinary approaches is still developing, emerging models demonstrate promise for improving outcomes while managing costs. The CMS Guiding an Improved Dementia Experience model, the GUIDE model, represents the most significant policy initiative supporting comprehensive dementia care in the United States. Launched in 2024, GUIDE provides enhanced Medicare payments for comprehensive dementia care, including care navigation, caregiver education and support, respite services, and coordination across healthcare settings. While definitive outcomes data are not yet available, the model has catalyzed health system attention to dementia care coordination and created financial incentives for developing integrated care programs. The care ecosystem model, developed and tested at the University of California, San Francisco, exemplifies evidence-based comprehensive dementia care. This model employs trained care navigators who conduct regular check-ins with patients and caregivers, facilitate access to community resources, provide caregiver support, and coordinate with healthcare providers. Randomized controlled trial evidence demonstrates improved patient quality of life, reduced emergency department use, delayed long-term care placement, and decreased caregiver depression and burden. Importantly, cost analyses found reductions in total healthcare spending, suggesting that comprehensive dementia care can produce savings sufficient to offset program costs. Interprofessional education during training represents a promising strategy for improving future collaboration. A 2024 qualitative study examining a collaborative dementia workshop for healthcare students found that shared learning experiences enhanced understanding of professional roles, built communication skills, and fostered appreciation for interdisciplinary approaches. Participants valued learning directly from persons with dementia and their caregivers as part of the educational experience. Effective care coordination requires structures and processes that facilitate communication, ensure continuity, and prevent fragmentation across providers and settings. Case management, whether provided by nurses, social workers, or other trained professionals, represents one model for coordinating dementia care. Case managers conduct comprehensive assessments, develop care plans, connect families with resources, monitor status over time, and adjust services as needs change. Care transitions, movements between settings such as hospital to home to nursing facility, or nursing facility to hospital, represent periods of particular vulnerability for persons with dementia. Information may be lost, medications changed, routines disrupted, and unfamiliar environments may provoke confusion and behavioral symptoms. Transition care interventions, including structured communication tools, medication reconciliation, caregiver education, and timely follow up, can reduce adverse outcomes. The dementia care pointers specifically address hospital discharge planning for persons with dementia. Technology increasingly supports care coordination through shared electronic health records, telehealth platforms, and care management applications. However, technology adoption in dementia care faces challenges including digital literacy among older caregivers, privacy concerns, and integration across healthcare systems. The potential for remote monitoring, virtual check ins, and digital communication with care teams remains substantial but incompletely realized. Family caregivers serve as de facto care coordinators for many persons with dementia, navigating healthcare systems, communicating with multiple providers, and managing day to day care. Formal care coordination models should complement rather than supplant caregiver efforts, providing support, information, and linkages that caregivers cannot access independently. Recognizing caregivers as partners in care coordination, rather than passive recipients of professional direction, respects their expertise and enhances collaboration. Translating evidence based dementia interventions into routine practice faces numerous barriers at individual, organizational, and system levels. Understanding these barriers is essential for designing effective implementation strategies and realistic expectations regarding practice change. Systematic reviews have consistently identified common barriers across diverse settings and intervention types. Staffing constraints represent the most frequently cited barrier to implementing evidence based dementia care. Inadequate staff to resident ratios in long term care settings limit time available for person centered interactions, individualized activities, and non pharmacological approaches to behavioral symptoms. High staff turnover disrupts continuity, wastes educational investments, and prevents development of the relationships essential for person centered care. In a 2025 scoping review comparing Western and Asian long term care settings, staffing shortages emerged as a principal barrier in both contexts, though specific challenges differed. Knowledge and attitudinal barriers include insufficient understanding of dementia, misconceptions about rehabilitation potential, therapeutic nihilism regarding intervention effectiveness, and negative attitudes toward persons with dementia. While education can address knowledge gaps, changing attitudes often requires more intensive interventions, including direct experience with successful outcomes, role modeling by respected peers, and organizational cultures that reinforce positive expectations. Organizational factors, including inadequate management support, competing priorities, lack of dedicated time for training and implementation, and absence of supportive policies impede practice change even when individual staff are motivated. A systematic review of barriers to complex intervention implementation in long-term care found that without organizational commitment, individual-level interventions typically fail to produce sustained change. Quality improvement methodologies provide structured approaches for implementing practice changes in dementia care. The Plan Do Study Act cycle offers a simple framework for testing and refining interventions. Plan a change, do implement it on a small scale, study the results, and act to adopt, adapt, or abandon based on findings. Iterative Plan Do Study Act cycles enable progressive refinement of interventions to fit local contexts. Implementation science frameworks such as the Consolidated Framework for Implementation Research provide comprehensive models for understanding factors affecting implementation success. This framework identifies 5 domains: intervention characteristics, including complexity, adaptability, and evidence strength; outer setting, including external policies and peer pressure; inner setting, including organizational culture and implementation climate; characteristics of individuals, including knowledge and self efficacy; and process, including planning, engagement, and execution. Systematic assessment across domains guides implementation planning and troubleshooting. Audit and feedback, providing practitioners with data on their performance relative to standards or peers, represents an evidence-based quality improvement strategy with modest but consistent effects on practice change. For dementia care, relevant metrics might include behavioral symptom documentation, non-pharmacological intervention use, antipsychotic prescribing rates, fall rates, or resident quality of life scores. Feedback is most effective when delivered by supervisors or respected colleagues, provided frequently, and accompanied by action plans for improvement. Facilitators of successful implementation provide the counterpoint to barriers, suggesting strategies for overcoming obstacles and achieving practice change. Person-centered organizational cultures that genuinely value the individuals receiving care create environments supportive of evidence-based practice. Strong leadership commitment to dementia care quality provides essential support for implementation. Leaders allocate resources, model desired behaviors, hold staff accountable, and communicate the importance of dementia care as an organizational priority. In studies of successful implementation, leadership support consistently emerges as a critical success factor. Staff education and training, when appropriately designed and delivered, facilitate implementation by building knowledge, skills, and confidence. However, education alone is typically insufficient. It must be combined with organizational support, resources, and accountability mechanisms. The most effective educational approaches are interactive, practice-based, delivered by experienced facilitators, and reinforced through ongoing supervision and feedback. Intervention adaptability, the capacity to modify implementation strategies to fit local contexts while preserving core components, supports successful uptake across diverse settings. Rigid protocols that cannot accommodate setting-specific constraints typically fail. Flexible approaches that allow local adaptation while maintaining fidelity to essential elements demonstrate better outcomes. The evidence base for dementia staff education has been systematically synthesized in multiple reviews, enabling identification of effective approaches. A 2023 overview of systematic reviews examining dementia education for professional care staff found consistent positive effects on knowledge, self-efficacy, and attitudes, with more variable effects on behavior change and resident outcomes. Content factors associated with effectiveness include focus on person-centered care principles, communication skills, behavioral symptom management, and directly applicable practical skills. Education addressing abstract concepts without clear application to daily practice demonstrates limited impact on behavior. Perceived relevance and immediate applicability are key elements for effective dementia education. Delivery factors influence educational effectiveness substantially. Active, interactive learning methods produce better outcomes than passive didactic approaches. Face-to-face delivery by experienced facilitators who understand the clinical context outperform standardized online modules. Practice-based components, including role-play, case-based learning, and supervised application-reinforced skill development. Theory-driven approaches grounded in adult learning principles and behavior change frameworks provide structure for educational design. Train-the-trainer models offer scalability for reaching large numbers of staff while maintaining quality. In these approaches, selected staff receive intensive training, enabling them to subsequently train colleagues. Systematic reviews support train-the-trainer effectiveness when trainers receive adequate preparation and ongoing support. However, quality can deteriorate with successive training generations if ongoing quality assurance is not maintained. Organizational support factors, including dedicated time for education, relief from patient care duties during training, and supportive supervision following training, predict sustained behavior change. Education provided without protected time or follow-up support typically produces only transient effects as staff return to usual routines and competing demands. Creating cultures of continuous learning that normalize ongoing professional development supports sustained practice improvement. Now let's turn to our sixth module, which covers outcome measurement, emerging therapies, safety, and cultural adaptation. Selection of appropriate outcome measures is essential for evaluating intervention effectiveness, documenting progress, and demonstrating value in dementia rehabilitation. A 2023 Global Intersocietal Delphi Consensus involving 20 voting members nominated by 10 professional societies established recommendations for outcomes and measures across 9 domains. This consensus provides authoritative guidance for clinicians and researchers selecting assessment instruments. Cognitive domain measures include the Mini Mental State Examination, known as the MMSE, and Montreal Cognitive Assessment, known as the MOCA, both clinician-administered screening tools with established reliability and validity. The MOCA demonstrates greater sensitivity for detecting mild cognitive impairment compared to MMSE, making it preferable for early-stage assessment. However, both instruments exhibit floor effects in advanced dementia, limiting utility for tracking change in later disease stages. The consensus identified 37 validated crosswalks enabling comparison of MMSE scores across studies. Functional ability measures address the activities of daily living that define dementia's practical impact. The Functional Independence Measure motor subscale is recommended for rehabilitation settings, with evidence suggesting that the motor subscale should be used rather than total FIM scores in dementia populations because cognitive subscale items may underestimate functional improvement. For community settings, the Functional Activities Questionnaire captures instrumental ADL performance relevant to independence. The Alzheimer's Disease Cooperative Study ADL scale provides a dementia-specific measure with established minimal clinically important difference of 2 points. Behavioral and neuropsychiatric symptom measures, particularly the Neuropsychiatric Inventory known as the NPI, become increasingly important as disease progresses and behavioral symptoms emerge. The NPI assesses 12 neuropsychiatric symptom domains through caregiver interview, yielding frequency and severity scores with a range of 1 to 144. The consensus noted increasing relevance of NPI scores as disease advances, in contrast to cognitive measures that become less sensitive. Quality of life measures capture outcomes that matter most to patients and families. The Quality of Life in Alzheimer's Disease Scale, known as QOL-AD, can be administered to patients when cognitively capable or to proxy respondents in moderate to advanced stages. The scale ranges from 4 to 52, with higher scores indicating better quality of life. Importantly, patient and proxy ratings often differ, with patients typically rating quality of life higher than caregivers perceive it. Caregiver burden measures recognize that dementia affects families as well as individuals. The consensus recommended the Dementia Burden Scale for caregivers, which is a composite of NPI distress, Modified Caregiver Strain Index, and PHQ-8, along with the Berlin Inventory of Caregiver Stress in Dementia, as validated options. Caregiver outcomes deserve attention in rehabilitation planning, as interventions reducing caregiver burden can enable continued community residence and improve family well-being. Practical considerations influence measure selection beyond psychometric properties. Administration time, training requirements, equipment needs, and respondent burden all affect feasibility in busy clinical settings. The MOCA requires approximately 10 to 15 minutes for administration. Longer batteries, such as comprehensive neuropsychological testing, may be impractical for routine clinical use, but valuable for differential diagnosis or research. Stage appropriateness guides measure selection. Cognitive screening tools designed for early detection exhibit floor effects in moderate to advanced dementia, reducing sensitivity to change. Advanced dementia may be better monitored through behavioral observation, caregiver-reported quality of life, and comfort indicators rather than cognitive testing. Conversely, measures designed for advanced populations may not capture the concerns of early-stage individuals who can self-report. Setting influences optimal measure selection. Inpatient rehabilitation settings may prioritize the FIM for consistency with broader rehabilitation populations and Medicare reporting requirements. Long-term care facilities may favor the minimum dataset given its integration with regulatory requirements. Community settings may emphasize patient-reported outcomes and instrumental ADL measures reflecting independence in real-world contexts. Repeated assessment enables tracking change over time but requires attention to learning effects, which may inflate scores on repeated cognitive testing. Alternate forms, where available, reduce practice effects. Clinicians should establish baseline assessments at admission or initiation of services and repeat at meaningful intervals, typically at discharge, at defined time points such as quarterly in long-term care or when clinical change is suspected. Cost-effectiveness evidence supports value arguments for dementia rehabilitation investment. A 2023 systematic review examining cost-effectiveness of non-pharmacological interventions found that several approaches demonstrate cost savings or cost neutrality compared to usual care. Most promising were multi-component interventions, indirect strategies such as group living and dementia care management, tailored occupational therapy, and psychosocial interventions for caregivers. The Care Ecosystem Collaborative Care Model demonstrated reductions in total healthcare spending sufficient to offset program costs, providing evidence that comprehensive dementia care can be financially sustainable. The UCLA Comprehensive Dementia Care Program showed reduced long-term care admissions with cost neutrality for Medicare after accounting for program costs. These findings counter assumptions that high-quality dementia care necessarily increases costs. Technology-based interventions present a mixed cost-effectiveness picture. Semi-immersive virtual reality using commercial gaming systems offers low upfront costs with potential for home-based delivery reducing clinic visits. Fully immersive VR carries higher equipment costs with insufficient economic evaluation data. Companion robots face similar limitations with high acquisition costs and inadequate cost-effectiveness evidence to justify investment. Telemedicine applications for dementia care expanded dramatically during the COVID-19 pandemic and have maintained relevance as sustainable care delivery options. A systematic review of telemedicine based cognitive rehabilitation found improvements in cognitive function, quality of life, and caregiver support with high adherence and satisfaction rates. Effect sizes for overall cognition, attention and execution, and memory support telemedicine as a legitimate intervention modality rather than merely a substitute for in person care. Wearable technologies and smart home systems offer potential for remote monitoring, safety alerts, and cognitive support. Applications include fall detection, wandering alerts, medication reminders, and environmental control. While evidence for clinical effectiveness is still developing, these technologies may extend independent living and reduce caregiver burden by providing safety monitoring without constant supervision. Mobile applications for cognitive training, daily activity support, and caregiver assistance continue to proliferate. A 2025 network meta analysis found that mobile device based games demonstrated the largest effect sizes for global cognition among digital intervention types. However, the quality of available applications varies widely, and therapist guidance in selecting appropriate options remains valuable. Fall prevention in dementia requires multi component approaches addressing the multiple risk factors that converge in this population. The World Guidelines for Falls Prevention and Management recommend multifaceted interventions for care home residents, combining staff training, decision support tools, and targeted prevention actions. Exercise training should be included as part of multi domain interventions when feasible and safe, with balance and strength training as core components. Environmental adaptations for fall prevention include improved lighting, removal of trip hazards, grab bars and handrails, non slip flooring, and bed height adjustment. For persons with dementia, additional considerations include minimizing confusing visual environments, ensuring adequate contrast between surfaces, and securing spaces to prevent access to hazardous areas while avoiding physical restraints that increase injury risk. Wandering management balances safety concerns with respect for autonomy and quality of life. Complete restriction of movement constitutes restraint and carries documented harms. Evidence based approaches include environmental modifications, creating safe wandering paths, structured routines, reducing restlessness, addressing underlying needs that may drive wandering behavior, and technologies such as GPS trackers and door alarms for detection rather than prevention. Medication safety in dementia involves both ensuring appropriate medication administration and preventing adverse drug events. Persons with early stage dementia may benefit from occupational therapy interventions developing compensatory strategies for medication management. As disease progresses, supervision and ultimately complete medication management by caregivers becomes necessary. Regular medication review with deprescribing of potentially inappropriate medications reduces adverse event risk and may improve cognition and function. Providing dementia care for culturally and linguistically diverse populations requires adaptation of standard approaches to ensure accessibility, acceptability, and effectiveness. Language barriers represent the most fundamental challenge, as assessment instruments validated in one language may perform differently in translation, and communication difficulties impede therapeutic relationships. Professional interpreter services are essential. Reliance on family members as interpreters raises confidentiality concerns and may introduce bias. Cultural factors influencing dementia care include beliefs about dementia causation, acceptability of formal services, family roles and expectations, communication styles, and end of life values. In many cultures, dementia carries significant stigma that delays help seeking and creates reluctance to discuss the diagnosis openly. Family centered decision making patterns may conflict with Western emphasis on individual autonomy. Religious and spiritual practices provide important sources of comfort and meaning that should be integrated into care rather than ignored. Culturally tailored interventions demonstrate acceptability and effectiveness when appropriately adapted. A 2021 systematic review examining culturally tailored therapeutic interventions found evidence supporting adapted cognitive stimulation therapy, reminiscence therapy, and multi component caregiver support programs. Effective adaptations involve community engagement in intervention design, use of culturally relevant materials and activities, delivery by culturally concordant staff or in partnership with community organizations, and attention to practical barriers including transportation and scheduling. Provider cultural competence development involves ongoing self-reflection regarding personal biases and assumptions, knowledge acquisition about specific cultural groups served, skill development in cross-cultural communication, and advocacy for systemic changes making services more accessible to diverse populations. Now let's bring everything together through 4 detailed case studies that illustrate application of evidence-based principles across different dementia stages, care settings, and clinical scenarios. Each case integrates content from the preceding modules, demonstrating how assessment, intervention selection, outcome measurement, and interprofessional collaboration occur in realistic clinical contexts. Our first case study examines early-stage Alzheimer's disease in an active retiree. Margaret Chen is a 72-year-old retired elementary school teacher who presents to an outpatient geriatric clinic accompanied by her husband David. She reports increasing difficulty with word finding, forgetting appointments, and misplacing items over the past 18 months. David confirms these observations and adds that Margaret has made errors when managing their household finances, something she previously handled independently, and has gotten lost driving to familiar locations on 2 occasions. Despite these difficulties, Margaret continues to dress herself appropriately, prepare meals, and maintain personal hygiene independently. Margaret's medical history includes well-controlled hypertension, hyperlipidemia, and osteoarthritis of both knees. Current medications are lisinopril 10 mg daily, atorvastatin 20 mg daily, and acetaminophen as needed for joint pain. She has no history of stroke, head injury, or psychiatric illness. Family history is significant for Alzheimer's disease in her mother, who was diagnosed at age 78 and died at 84. Social history reveals that Margaret taught 3rd grade for 35 years before retiring at age 65. She and David have been married for 48 years and have 2 adult children who live out of state. Margaret has been active in a book club that meets monthly, tends a vegetable garden, and provides after-school care for her 3 grandchildren twice weekly. David, age 74, is in good health and manages most household maintenance tasks. Neuropsychological testing reveals Montreal Cognitive Assessment score of 21 out of 30, with deficits in delayed recall, orientation, and executive function. Verbal fluency is reduced at 12 animals in 1 minute. These findings indicate cognitive impairment exceeding normal aging. Functional Activities Questionnaire score is 8 out of 30, indicating mild functional impairment primarily affecting complex instrumental activities including financial management, remembering appointments, and traveling outside familiar areas. Brain MRI shows bilateral hippocampal atrophy and mild periventricular white matter hyperintensities consistent with small vessel disease. No acute infarcts, mass lesions, or significant cortical atrophy are present. Amyloid PET imaging demonstrates elevated cortical amyloid binding consistent with Alzheimer's disease pathology. Laboratory studies, including complete blood count, comprehensive metabolic panel, thyroid function, and vitamin B12 level, are within normal limits. Based on comprehensive evaluation applying 2024 Alzheimer's Association diagnostic criteria, the team diagnoses mild Alzheimer's disease with high confidence. The care team includes a geriatrician serving as care coordinator, neuropsychologist, physical therapist, occupational therapist, and social worker. Margaret and David participate actively in care planning, reflecting Margaret's retained decision-making capacity. The team conducts discipline-specific assessments to inform collaborative treatment planning. Physical therapy assessment reveals timed up and go of 11 seconds, which is within normal limits. Berg Balance Scale score of 52 out of 56, indicating low fall risk, and 30-second chair stand of 12 repetitions, which is age appropriate. Margaret reports walking for exercise 2 to 3 times weekly, but has reduced activity recently due to concerns about getting lost. She has no history of falls in the past year. Gait observation shows mildly reduced arm swing and slightly shortened stride length, but no major abnormalities. Occupational therapy assessment examines functional cognition and daily activity performance. The Canadian Occupational Performance Measure identifies Margaret's priority concerns as managing finances without errors, driving safely to maintain independence, continuing her garden, and remaining a reliable caregiver for her grandchildren. Kitchen task observation reveals difficulty sequencing steps in a multi-component recipe, though she completes familiar simple meals without difficulty. She demonstrates capacity to learn compensatory strategies when provided structured instruction. Based on comprehensive assessment and discussion with Margaret and David, collaborative goals are established, maintaining current level of independence in basic ADLs for as long as possible, developing compensatory strategies for IADL challenges, particularly financial management and appointment tracking, maintaining physical fitness and cardiovascular health while ensuring exercise safety, preserving meaningful social engagement through book club, gardening, and grandchild care, completing advanced care planning, while Margaret retains capacity to articulate her values and preferences, and supporting David in his emerging caregiver role through education and resource connection. Physical therapy initiates a multi-component exercise program based on evidence supporting combined aerobic, resistance, and balance training for early-stage dementia. The program involves 60-minute sessions 3 times weekly for 12 weeks initially, with planned transition to community-based maintenance. Each session includes 20 minutes of aerobic exercise on stationary cycling and treadmill walking at 60 to 70% maximum heart rate, 20 minutes of resistance training targeting major muscle groups using weight machines and resistance bands, and 20 minutes of balance and coordination activities including tandem stance, single leg standing, and obstacle negotiation. Dual task training is incorporated progressively, with Margaret performing cognitive tasks such as counting backwards by threes, verbal fluency exercises, and reciting family birth dates while walking or performing balance activities. Margaret expresses interest in continuing Tai Chi, which she practiced years ago. The physical therapist identifies a community Tai Chi class appropriate for older adults and coordinates with the instructor regarding Margaret's cognitive status. David agrees to accompany Margaret to classes initially to ensure she can follow along and navigate the location. The physical therapist provides the Tai Chi instructor with strategies for cueing and supporting participants with memory difficulties. Occupational therapy focuses on cognitive rehabilitation and compensatory strategy training across 12 weekly sessions. Errorless learning techniques are used to train Margaret in using a smartphone calendar application synchronized with a large wall calendar for appointment tracking. The therapist provides step-by-step written instructions and practices the procedure repeatedly until Margaret can demonstrate reliable use. A medication management system with weekly pill organizer and smartphone alarms is implemented with similar systematic training. Financial management interventions include simplifying the bill-paying system, establishing automatic payments for recurring bills, and creating a joint checking account with David that allows him to monitor for errors while Margaret maintains involvement. The occupational therapist recommends that David assume primary responsibility for complex financial decisions while Margaret continues to handle routine transactions to maintain engagement and self-efficacy. Driving safety is addressed through comprehensive evaluation, including on-road assessment by a certified driver rehabilitation specialist. Results indicate that Margaret can continue driving under specific conditions: familiar routes only, daytime hours with good visibility, no adverse weather, and use of GPS navigation consistently. Margaret and David sign a driving contract specifying these limitations and agreeing to cease driving if specified warning signs occur, such as another episode of getting lost, any accident regardless of fault, or increased anxiety while driving. Reevaluation is scheduled for 6 months. The social worker facilitates advanced care planning discussions over 2 sessions, helping Margaret articulate her values and preferences for future care decisions. Margaret identifies quality of life, maintaining relationships with family, and avoiding prolonged suffering as core values. She completes a healthcare proxy designating David as her decision maker, with her daughter as alternate. She documents preferences regarding future care intensity, indicating that she would not want aggressive life-prolonging treatment if she reaches advanced dementia, but would want comfort-focused care allowing natural death. These documents are uploaded to the electronic health record and copies provided to family members. The social worker connects Margaret with a local early-stage dementia support group that meets twice monthly, providing peer support and practical strategies from others navigating similar challenges. David is connected with a caregiver support group and provided educational materials from the Alzheimer's Association. The social worker also researches adult day programs and respite services for future reference, recognizing that needs will evolve. At 6-month follow-up, Margaret's MOCA score is 20 out of 30, representing a 1-point decline that falls within measurement error and suggests relative stability. FAQ score remains at 8 out of 30, indicating maintained functional status. Physical therapy reassessment shows maintained balance and improved cardiovascular endurance as evidenced by increased treadmill duration. She has had no falls and continues Tai Chi classes with David's support. Margaret successfully uses her smartphone calendar system with minimal errors and has not missed any scheduled appointments. She continues preparing familiar meals with occasional use of written recipe cards. She has had no further driving incidents in 6 months and reports reduced anxiety while driving with consistent GPS use. She continues attending her book club, now using written notes to remember discussion points, and has modified her grandchild care to focus on activities within her abilities, with David providing backup supervision. David reports feeling more confident in supporting Margaret and less anxious about the future, having established concrete plans and support systems. He attends caregiver support group monthly and has begun researching long-term care insurance options. The couple has discussed their situation with their adult children, who have committed to increasing involvement as needs progress. The team establishes ongoing monitoring plans, including quarterly check ins with the social worker, semi annual cognitive reassessment, annual driving reevaluation, and criteria for escalating services such as significant functional decline, behavioral symptoms, caregiver burnout, or safety incidents. Margaret expresses satisfaction with her current quality of life, measured at 38 out of 52 on the QOL ad, while acknowledging the progressive nature of her condition and appreciating the support system in place. Our second case study examines moderate stage dementia with behavioral symptoms in long term care. Robert Williams is an 81-year-old African American man with moderate Alzheimer's disease residing in a skilled nursing facility for 6 months. He was admitted following a hospitalization for community acquired pneumonia, during which his wife Evelyn could no longer manage his care at home, despite support from home health aides. Before admission, Robert had been living with Evelyn in their home of 45 years. Over the past 2 months, nursing staff report increasing agitation, particularly during morning care, with verbal aggression towards certified nursing assistants and occasional physical resistance to bathing. These behaviors have resulted in incomplete care on several occasions and staff reluctance to work with Robert. Robert's medical history includes Alzheimer's disease diagnosed 4 years ago, hypertension, type 2 diabetes, benign prostatic hyperplasia, and hearing loss requiring bilateral hearing aids. Current medications include donepezil 10 mg daily, memantine 10 mg twice daily, lisinopril 20 mg daily, metformin 500 mg twice daily, and tamsulosin 0.4 mg at bedtime. He has no history of psychiatric illness or aggressive behavior prior to dementia onset. Review of records shows MMSE score 14 out of 30 documented 3 months ago, consistent with moderate dementia. Robert requires assistance with bathing, dressing, and toileting, but can feed himself with setup assistance and walks independently with supervision. He recognizes his wife Evelyn consistently, but sometimes does not recognize staff members, occasionally mistaking CNAs for intruders. Sleep records indicate frequent nighttime wakefulness with wandering in the hallway 2 to 3 times weekly. Social history obtained from Evelyn reveals that Robert was a postal worker for 35 years, retiring at age 66. He served in the Army in Vietnam and was active in his church and local veterans organization. He enjoys jazz music, particularly Miles Davis and John Coltrane, and was an avid baseball fan who followed the local team closely. He worked the evening shift from 3 p.m. to 11 p.m. for most of his career and was never a morning person even in retirement. Evelyn visits daily in the afternoon and describes Robert as kind and gentle throughout their 55-year marriage, making his current aggressive behavior particularly distressing. The interdisciplinary team applies the DICE framework to systematically address Robert's behavioral symptoms. The team includes the attending physician, director of nursing, unit nurse manager, certified nursing assistants who provide direct care, occupational therapist, social worker, and Evelyn as family representative. For the described step, staff complete behavioral logs over 2 weeks, documenting that agitation occurs primarily during morning care between 7 a.m. and 8:30 a.m., most frequently during bathing and dressing. Robert makes statements such as, "Get away from me, I don't know you, leave me alone, and I need to get to work." Behaviors include pushing caregivers' hands away, attempting to leave the bathroom, and on one occasion swinging his arm toward a CNA without making contact. Episodes occur with both male and female staff, but are more intense with unfamiliar staff, particularly float personnel from other units. Episodes typically last 5 to 15 minutes and resolve when care is discontinued and Robert is left alone briefly. For the investigate step, medical evaluation rules out urinary tract infection, constipation, and acute pain conditions. Review of vital signs shows no fever or significant blood pressure changes. Medication review identifies no recent changes and no obvious medications causing agitation. Donepezil and memantine have been stable for over a year. Hearing aids are checked and found to be functioning with fresh batteries. Environmental analysis reveals that morning care occurs in a small tiled bathroom with bright overhead fluorescent lighting, hard surfaces creating echo, and typically 2 staff members present. The bathroom is cool in the morning, and Robert visibly shivers when undressed. The standard care approach involves waking Robert at 7 a.m. to meet facility routines, approaching quickly to complete care efficiently, and using task-focused communication. Investigation of psychosocial factors, informed by Evelyn and Robert's history, reveals several potential contributors. Robert worked evening shifts throughout his career and never functioned well in early morning. As a proud, private man, he finds it distressing to be bathed by strangers, particularly young women. His military service may contribute to vigilance and defensive responses when approached unexpectedly. His statements about needing to get to work suggest he may be experiencing morning disorientation, believing he is still employed. The unfamiliar bathroom environment differs markedly from his home bathroom of 45 years. For the create step, the intervention plan addresses multiple factors. Environmental modifications are implemented. Bathroom fluorescent lights are replaced with warmer LED bulbs on a dimmer, allowing gradual brightening rather than sudden harsh light. A small space heater warms the bathroom before care begins, and towels are warmed in a towel warmer. A portable speaker plays Robert's preferred jazz music quietly during care. Care is restructured to involve only one CNA rather than two staff, reducing perceived threat. Robert's own bathrobe from home replaces the facility gown. Care timing and approach are modified substantially. Working with the attending physician and nursing leadership, Robert's care schedule is shifted to 9 a.m. when staffing permits, allowing him to wake naturally. On days when earlier care is necessary, staff allow 30 minutes from wake-up to care initiation. CNAs are instructed to approach Robert slowly from the front. Ensure hearing aids are in place before attempting communication. Make eye contact, introduce themselves by name each time, and explain each step before performing it. Communication is adapted to Robert's history and preferences. Staff address him as Mr. Williams rather than his first name, respecting his generation's formality norms. When he expresses urgency about work, staff validate rather than correct, acknowledging that he is thinking about important things and suggesting they get him ready for the day. Offering choices such as whether he would like to wash his face first or have help with his shirt provides a sense of control. Staff assignment protocols ensure continuity. Two CNAs, Teresa and Michael, who have developed rapport with Robert, are designated as his primary caregivers and assigned to his care whenever they are working. These staff receive additional training in dementia communication from the occupational therapist and are offered a small shift differential in recognition of their specialized skills. When primary staff are unavailable, the charge nurse introduces covering staff to Robert with Evelyn present when possible. Occupational therapy develops a personalized activity program informed by Robert's life history. A reminiscence box is created containing photographs from his postal career, including his retirement celebration, his Army service, including basic training photo and unit insignia, his wedding, and family gatherings. Jazz music playlists curated by Evelyn are loaded onto a tablet accessible in his room. Staff are trained to use these materials for engagement, particularly during periods of restlessness. Scheduled viewing of baseball games in the common area is arranged with other interested residents, providing social engagement and structured activity. Sleep intervention addresses nighttime wakefulness contributing to morning difficulty. Light exposure is increased during daytime through positioning near windows and encouraging participation in outdoor activities when weather permits. Evening routines are established, including dimmed lighting after dinner, cessation of caffeinated beverages, and calming music during evening care. When Robert does wake at night, staff guide him gently back to bed rather than attempting to restrict movement, using orientation cues such as noting that it is nighttime and his wife Evelyn will visit tomorrow afternoon. For the evaluate step, behavioral logs at 4-week follow-up show 60% reduction in agitation episodes during morning care. When episodes occur, they are shorter, typically less than 5 minutes versus 10 to 15 minutes previously, and less intense with verbal expressions without physical resistance. No episodes of swinging or striking have occurred since intervention implementation. Robert's NPI agitation subscale score decreased substantially. Sleep monitoring shows reduced nighttime wandering from 2 to 3 times weekly to once weekly. Staff surveys indicate improved confidence in caring for Robert and willingness to work with him. Teresa and Michael report satisfaction with their specialized roles and appreciation for the additional training. Evelyn expresses gratitude for the individualized approach, noting that staff now seem to know Robert as a person rather than just a difficult patient. She observes that Robert appears calmer during her visits and has resumed enjoying jazz music together. She has begun participating in a family support group offered by the facility. The team plans to continue current interventions with ongoing monitoring. Monthly care conferences will review behavioral data and adjust approaches as needed. The team discusses anticipatory planning for eventual decline, including goals of care should acute illness occur, and family preferences regarding hospitalization versus comfort care in place. Documentation of successful strategies is prominently placed in Robert's care plan to inform any future care transitions. Our third case study examines advanced dementia with multiple comorbidities. Dorothy Martinez is an 88-year-old Latina woman with advanced Alzheimer's disease residing in a memory care unit within an assisted living facility. She has been in the current facility for 2 years following progressive decline that exceeded her family's home care capacity. Dorothy has minimal verbal output, limited to occasional single words such as yes, no, and Maria, along with unintelligible vocalizations. She does not consistently recognize her daughter Maria, who visits several times weekly, though she sometimes smiles and reaches for Maria's hand. Medical history is complex, including Alzheimer's disease diagnosed 8 years ago, heart failure with reduced ejection fraction of 35% on recent echocardiogram, chronic kidney disease stage 3B osteoporosis with T-score of -3.2, severe osteoarthritis of hips and knees, and chronic constipation. Current medications include donmezil 10 milligrams daily, continued per family preference, though benefit at this stage is uncertain. Furosemide 40 milligrams daily, potassium chloride 20 milliequivalents daily, docusate 100 milligrams twice daily, and polyethylene glycol daily. She has a history of 2 hospitalizations in the past year for heart failure exacerbation and urinary tract infection. Functional status assessment indicates complete dependence in all activities of daily living. Dorothy requires total assistance with bathing, dressing, toileting with incontinence of bladder and bowel, and transfers requiring two-person assist with mechanical lift. She takes nutrition orally with extensive assistance, and feeding takes 45 to 60 minutes per meal with frequent cueing to open mouth, chew, and swallow. Speech-language pathology evaluation 3 months ago identified moderate oropharyngeal dysphagia with risk of aspiration. Mechanical soft diet with nectar-thick liquids was recommended. Weight has declined from 145 pounds at admission to 118 pounds currently, despite nutritional supplementation. Dorothy has experienced 3 falls in the past 6 months. One from bed when side rails were not in use per facility policy against restraints, one during transfer due to lift malfunction, and one when she slid from wheelchair because the positioning belt was loose. All resulted in bruising but no fractures, attributed partly to her osteoporosis, making the absence of fractures surprising given the mechanism of injury. She is considered at extremely high fall risk. Maria, age 62, is Dorothy's only living child and holds healthcare power of attorney. She is a retired nurse who provides informed, engaged advocacy for her mother's care. Maria has 2 adult children who visit their grandmother monthly. Maria describes her mother as a devout Catholic who attended Mass weekly throughout her life, valued family above all else, and explicitly stated before her decline that she would not want to be kept alive by machines if she lost her mind. Dorothy's husband Carlos died 15 years ago from lung cancer. Maria describes her mother as having been ready to join him even before dementia onset. A comprehensive care conference is convened including the attending physician, nurse practitioner, director of nursing, floor nurse, certified nursing assistants, physical therapist, occupational therapist, speech-language pathologist, social worker, chaplain, and Maria. The purpose is to review Dorothy's current status, discuss goals of care, and develop an updated care plan aligned with her values and family wishes. The physician presents Dorothy's medical status, noting progressive decline consistent with advanced dementia trajectory, heart failure that has required 2 hospitalizations, marginal nutritional status despite intensive feeding support, and aspiration risk that may increase with continued decline. Median survival for patients with Dorothy's profile is estimated at 6 to 18 months, though individual prognosis is uncertain. Maria shares her understanding of her mother's values, drawing on explicit conversations before Dorothy's decline and lifetime knowledge of her character. Dorothy valued being present with family, practicing her faith, maintaining dignity, and avoiding prolonged suffering. She was uncomfortable with the deaths of relatives who received aggressive treatment in intensive care units and explicitly stated she wanted to go naturally when her time came. Maria has been Dorothy's caregiver for years and feels confident in her understanding of these wishes. Following discussion, Maria confirms that goals of care should prioritize comfort and quality of life rather than life prolongation. She requests a do not resuscitate and do not intubate order, wishes to avoid hospitalization if possible, and prefers that acute illnesses be managed in place with comfort measures. She understands the implications of dysphagia and potential aspiration, and chooses continued careful oral feeding rather than feeding tube placement, accepting the associated risks. She requests that her mother continue to receive basic medical care such as antibiotics for symptomatic infections and treatment of pain but not aggressive interventions. These decisions are documented as pulsed orders and in the facility care plan. Pain assessment and management become a priority, as Dorothy cannot reliably report pain, but behavioral indicators suggest potential discomfort. The nursing staff are trained in using the pain assessment in advanced dementia scale known as PAIN-AD, which assesses breathing, negative vocalization, facial expression, body language, and consolability. Baseline assessment, when Dorothy appears comfortable, yields a score of 1 out of 10. Scheduled acetaminophen 650 milligrams 3 times daily is initiated for presumptive osteoarthritis pain, with reassessment showing improved pain-AD scores and reduced grimacing during movement. Low-dose morphine 2.5 milligrams is made available for breakthrough pain or respiratory distress. Physical therapy focuses on comfort and prevention of complications rather than functional improvement. Interventions include positioning protocols to prevent pressure injuries and contractures, with repositioning scheduled every 2 hours when in bed and regular position changes in wheelchair. Gentle passive range of motion is performed during morning care to maintain joint mobility and provide tactile stimulation. The physical therapist trains nursing staff in proper positioning and transfer techniques to minimize pain and prevent falls. High-density foam mattress overlay is provided for pressure redistribution. Fall prevention focuses on environmental and supervision strategies rather than restraints, consistent with evidence that restraints increase rather than decrease injury risk. Dorothy's bed is lowered to its minimum height with high-density floor mats alongside. Motion sensor alerts staff when she attempts to move from bed or wheelchair. The malfunctioning lift is repaired and staff retrained in proper use. Wheelchair positioning is reassessed by occupational therapy, with a custom cushion and positioning supports providing better stability. Despite these measures, the team acknowledges that some fall risk is inherent and acceptable in a comfort-focused care approach that does not restrict movement. Nutritional approach emphasizes pleasure and comfort rather than caloric optimization. Based on speech-language pathology recommendations and Maria's preferences, Dorothy continues receiving mechanical soft diet with nectar-thick liquids via careful hand feeding. Feeding is provided in a calm, quiet environment with adequate time, up to 1 hour per meal, and discontinued if Dorothy shows signs of fatigue or refusal. Favorite foods from Dorothy's cultural background, including flan, arroz con leche, and soft tamales, are incorporated when available. The team documents that feeding tube will not be pursued if oral intake becomes insufficient, and that reduced intake is expected and accepted as part of natural decline. Sensory and spiritual interventions provide comfort and maintain connection. Dorothy's room contains family photographs, her rosary, and a small statue of the Virgin Mary. Spanish-language religious music plays softly during wakeful periods. Maria brings recordings of Dorothy's favorite telenovela theme songs. The facility chaplain visits weekly, leading the rosary prayer at Dorothy's bedside. Maria is encouraged to continue her visits focused on presence, holding Dorothy's hand, brushing her hair, and applying lotion, rather than attempting conversation that may frustrate both. Using the QOL ad proxy version completed by Maria and nursing staff, along with systematic behavioral observation, the team monitors Dorothy's apparent comfort and quality of life. Over the 3 months following the care conference, behavioral indicators suggest improved comfort with systematic pain management. Pain-AD scores average 1 to 2 out of 10 during routine care. Dorothy demonstrates positive responses to music by turning toward speaker with relaxed facial expression, and to Maria's visits through eye contact, occasional smiles, and reaching for hand. Weight stabilizes at 116 pounds with continued decline in oral intake. 6 months after the care conference, Dorothy develops fever and productive cough consistent with pneumonia. Following documented goals of care, she is treated in place rather than transferred to hospital. Oral antibiotics are initiated for comfort, as untreated pneumonia would likely cause distressing respiratory symptoms, along with increased morphine for respiratory distress. Maria is notified and spends extended time at the bedside, joined by her adult children who travel to be present. Over the following week, Dorothy's condition fluctuates. She has periods of responsiveness alternating with somnolence. Oral intake declines to minimal sips of water. The hospice team, engaged when prognosis shortened, provides additional support including symptom management, spiritual care, and family support. Dorothy dies peacefully with Maria and 1 grandchild present, 8 days after pneumonia onset. The facility provides bereavement support to Maria, including a condolence visit from Dorothy's primary CNA and information about grief resources. At a subsequent family meeting, Maria expresses gratitude that her mother's final months were comfortable and that her dying was peaceful and aligned with her values. The team documents the case as an exemplar of successful, comfort-focused care in advanced dementia. Our 4th case study examines a culturally diverse patient and family. Nguyen Van Minh is a 76-year-old Vietnamese immigrant man diagnosed with mixed Alzheimer's disease and vascular dementia 2 years ago following a stroke that left mild residual right-sided weakness. He speaks limited English, able to understand simple phrases and communicate basic needs, but unable to follow complex instructions or engage in detailed conversation without Vietnamese language support. Vietnamese is his primary language for emotional expression and complex communication. Mr. Nguyen immigrated to the United States 30 years ago as a refugee following the Vietnam War. He worked as a machinist until retirement at age 70. He lives with his son Tuan, age 48, daughter-in-law Lynn, age 45, and their two teenage children in a single-family home. Tuan works full-time as an electrical engineer. Lynn, a former accountant who left the workforce to care for her father-in-law, has been the primary caregiver for 2 years. The family attends a Vietnamese Buddhist temple monthly. Cultural context is essential for understanding this family's situation and designing appropriate interventions. In Vietnamese culture, filial piety, the duty of children to care for aging parents, is a deeply held value. Caring for Mr. Nguyen at home rather than placing him in a nursing facility reflects both cultural expectations and family honor. Lin's role as daughter-in-law caregiver aligns with traditional gender roles, though it creates substantial burden as she has essentially given up her career and personal activities. Placement in a nursing home would carry significant stigma within the Vietnamese community, potentially reflecting poorly on Tuan's character and the family's reputation. Dementia carries particular stigma in Vietnamese culture, often attributed to past misdeeds or family shame rather than understood as a medical condition. The family has not discussed Mr. Nguyen's diagnosis with extended family members or community members, instead attributing his difficulties to old age and the stroke. This concealment limits access to informal support that might otherwise be available through community networks. Lynn reports feeling isolated in her caregiving role, unable to share her struggles with friends or seek help from the temple community. Mr. Nguyen was referred to a home-based dementia care program following 2 emergency department visits, one for a fall that resulted in hip contusion and one for a caregiver crisis when Lynn experienced chest pain that was ultimately diagnosed as panic attack related to caregiver stress. The referral came from the ED social worker who recognized that the family needed support beyond what Lynn could provide alone. The care team engages a Vietnamese medical interpreter for all clinical encounters, recognizing that family members should not serve as interpreters for clinical discussions due to confidentiality concerns and potential for bias or filtering of sensitive information. The interpreter, herself Vietnamese American, provides not only language translation but cultural brokering, helping the clinical team understand cultural context and communicate in culturally appropriate ways. Cognitive assessment requires careful consideration given language barriers. The MOCA, available in validated Vietnamese translation, is administered by the interpreter under neuropsychologist guidance, yielding a score of 16 out of 30 consistent with moderate dementia. However, the neuropsychologist notes that Mr. Nguyen's limited formal education of 6 years in rural Vietnam affects interpretation, as many test items assume literacy and exposure to Western cognitive frameworks. Functional assessment through observation and caregiver interview provides more reliable information about Mr. Nguyen's abilities and care needs. Home visit assessment by occupational therapy reveals the family's living arrangement and cultural practices. Mr. Nguyen has a bedroom on the first floor, important given stair climbing difficulty from his stroke. A Buddhist altar in the living room is the site of daily prayers. Mr. Nguyen sits before the altar each morning, though Lynn reports he sometimes forgets the prayers he recited throughout his life. Traditional Vietnamese meals are prepared by Lynn, providing familiar foods that Mr. Nguyen enjoys. Extended family photographs cover one wall, including images from Vietnam that Mr. Nguyen can identify and discuss in Vietnamese. Caregiver assessment using the Zaret Burden Interview Vietnamese version reveals severe burden, with Lynn scoring 62 out of 88. She describes exhaustion, loss of personal identity, resentment she feels guilty about, and physical symptoms including headaches and sleep disturbance. She acknowledges that asking for help feels like admitting failure but recognizes she cannot continue without support. She expresses fear that accepting outside help would lead to judgment from the Vietnamese community and pressure from extended family to try harder. Physical therapy develops an intervention plan respecting Mr. Nguyen's cultural background and communication needs. The physical therapist learns several Vietnamese phrases for encouragement and basic instruction, supplemented by demonstration and hand-over-hand guidance. Exercise programming incorporates Tai Chi movements, which are culturally familiar and valued in Vietnamese tradition, rather than exclusively Western exercise forms. The physical therapist identifies that Mr. Nguyen enjoyed gardening in Vietnam and creates a seated gardening activity combining upper extremity exercise with meaningful occupation. Rather than framing physical therapy as treatment for deficits, the therapist presents it as promoting strength and wellness, a framework more consistent with Mr. Nguyen's cultural values than rehabilitation's emphasis on disability. Tuan is taught exercises he can supervise at home, framed as participation in his father's care that honors filial responsibility rather than delegation to outsiders. This framing enhances Tuan's engagement and addresses potential resistance to outside involvement. Occupational therapy focuses on maintaining Mr. Nguyen's participation in meaningful cultural practices and adapting activities to his abilities. The morning prayer routine at the Buddhist altar is preserved as an anchor activity, with visual cues such as photographs of temple and prayer beads supporting initiation and sequencing. Lynn is taught to sit beside her father-in-law during prayers rather than prompting from across the room, providing modeling and gentle physical guidance. Traditional Vietnamese cooking activities are adapted so Mr. Nguyen can participate in safe components like washing vegetables, stirring, and tasting, while Lynn manages hot surfaces and sharp implements. Reminiscence interventions incorporate Vietnamese music from Mr. Nguyen's young adulthood, photographs from Vietnam, and discussion in Vietnamese, with Lynn translating highlights for the therapist of memories from his life history. These activities show particular engagement, with Mr. Nguyen becoming more animated and verbal when discussing his village, his military service with the South Vietnamese Army, and his early married life. An audio recording of a Vietnamese monk chanting Buddhist sutras is obtained from the temple and played during rest periods. Caregiver support for Lynn addresses her isolation and burden through multiple strategies. The social worker identifies a Vietnamese community health worker employed by the local health department who can provide culturally concordant support, visiting monthly to check on the family, answer questions in Vietnamese, and serve as a bridge to formal services. The social worker also identifies a Vietnamese adult day health program that Mr. Nguyen can attend 2 days weekly, providing Lynn with regular respite while maintaining Mr. Nguyen in a Vietnamese-speaking environment with culturally familiar activities and food. Family intervention addresses the broader family system. The social worker facilitates a family meeting including Tuan, Lynn, and Tuan's 2 siblings, one local and one participating by video, to discuss care responsibilities. Using a culturally sensitive approach that acknowledges the eldest son's traditional leadership role while gently advocating for shared responsibility, the social worker helps the family recognize that Lynn cannot sustain current caregiving intensity alone. The siblings agree to contribute financially to respite care, visit more regularly to provide Lynn breaks, and take Mr. Nguyen for weekend stays monthly. This is framed as collective family honor rather than individual failure. Gradual community reintegration is approached carefully. Lynn tentatively discusses her father-in-law's condition with one trusted friend from Temple, finding unexpectedly supportive response. The friend shares that her own mother has similar difficulties, creating mutual support. The social worker provides Lynn with educational materials in Vietnamese about dementia as a medical condition, which Lynn shares with extended family, beginning to shift understanding from shame to compassion. At 3-month follow-up, outcome measurement demonstrates meaningful improvements across multiple domains. Mr. Nguyen has had no further falls with environmental modifications including grab bars in bathroom, removal of throw rugs, and improved lighting, along with daily Tai Chi practice supervised by Tuan. He attends the Vietnamese Adult Day program 2 days weekly and appears to enjoy the social interaction with Vietnamese-speaking peers and familiar cultural activities. MOCA score is stable at 15 out of 30. Lynn's Zaret burden score has improved from 62 to 44, still indicating moderate burden but substantially reduced from severe. She reports sleeping better, having resumed limited social activities during respite time, and feeling less isolated with support from the community health worker and her friend from Temple. She has begun attending a general caregiver support group with interpretation support and finds value in connection with other caregivers despite cultural differences. The family has discussed Mr. Nguyen's condition with key extended family members, finding the response more supportive than feared once dementia was explained as a medical condition rather than a character flaw. The family remains committed to home-based care as long as feasible, but has begun discussing future options should care needs exceed home capacity. The care team provides information about Vietnamese-speaking staff at local nursing facilities and assures the family that any future transitions would be approached gradually with cultural considerations paramount. This case illustrates that high-quality dementia care for culturally diverse families requires adaptation at multiple levels: language access, cultural understanding, intervention design, caregiver support, and community integration. Working with rather than against cultural values, framing outside support as enhancement of family caregiving rather than replacement, enables families to accept help while maintaining cultural identity and community standing. Now, let me bring this comprehensive course to a close with a summary of the key principles and takeaways. This continuing education course has provided a comprehensive, evidence based update on Alzheimer's disease and dementia rehabilitation and management for allied health professionals. The content synthesizes findings from systematic reviews, meta analysis, clinical practice guidelines, and expert consensus published between 2022 and 2025, representing the current state of knowledge in dementia care. Stage specific intervention represents a foundational principle. The goals, methods, and expected outcomes of dementia rehabilitation differ substantially across early, moderate, and advanced disease stages. Early stage interventions emphasize maintaining function through cognitive rehabilitation, compensatory strategies, multi component exercise, and advanced care planning. Moderate stage approaches focus on behavioral symptom management using the DICE framework, activity adaptation, sensory stimulation, and intensified caregiver support. Advanced stage care prioritizes comfort, quality of life, and palliative principles, with intervention focused on preventing complications and ensuring dignified end of life care. Physical exercise has emerged as one of the most effective non pharmacological interventions available. Meta analyses consistently demonstrate benefits for cognition, function, and behavioral symptoms. Multi component programs combining aerobic, resistance, and balance training show superior outcomes to single modality approaches. Physical cognitive rehabilitation integrating motor and cognitive demands demonstrates particular promise. Exercise parameters should be adapted to disease stage, with evidence suggesting shorter, more frequent sessions of 30 minutes 4 to 5 times weekly for moderate stage dementia compared to longer sessions of 60 minutes 2 to 3 times weekly appropriate for early stage individuals. Non-pharmacological approaches constitute first-line treatment for behavioral and psychological symptoms of dementia. The DICE framework provides structured methodology for systematically assessing underlying causes and designing individualized interventions. Personally tailored approaches demonstrate greater effectiveness than standardized protocols. Massage and touch therapy show strongest evidence for agitation reduction, while music therapy demonstrates benefits across multiple symptom domains. These non-pharmacological approaches should be implemented before considering psychotropic medications, which carry significant risks in dementia populations. Implementation requires organizational support beyond individual clinician knowledge. Successful practice change demands leadership commitment, adequate staffing, protected time for evidence-based practices, and organizational cultures that genuinely value person-centered care. Staff education is most effective when interactive, practice-based, delivered by experienced facilitators, and reinforced through ongoing supervision and feedback. Implementation science frameworks guide systematic assessment of barriers and facilitators, supporting realistic planning for practice improvement. Outcome measurement should be comprehensive, stage-appropriate, and aligned with what matters to patients and families. The 2023 Global Delphi Consensus provides authoritative guidance for selecting validated measures across cognitive, functional, behavioral, quality of life, and caregiver domains. Clinicians should recognize that some instruments demonstrate floor or ceiling effects in certain populations, limiting utility for tracking change. Cultural adaptation ensures equitable access to high-quality dementia care. Language barriers, cultural beliefs about dementia, family decision-making patterns, and stigma all influence care across diverse populations. Professional interpreter services are essential. Reliance on family members introduces bias and confidentiality concerns. Culturally tailored interventions demonstrate acceptability and effectiveness when designed with community engagement, delivered by culturally concordant providers, and adapted to specific cultural values and practices. Comprehensive dementia care models integrating care coordination, caregiver support, and wraparound services demonstrate both effectiveness and cost-effectiveness. Programs such as the Care Ecosystem and the CMS Guide model show that coordinated care can improve patient and caregiver outcomes while reducing healthcare costs through decreased emergency department use and delayed institutional placement. Investment in comprehensive dementia care is justified on clinical, ethical, and economic grounds. Allied health professionals, including physical therapists, occupational therapists, nurses, and others, play essential roles in the comprehensive care that persons with dementia and their families need and deserve. Through skilled assessment, evidence-based intervention, interdisciplinary collaboration, and attention to implementation factors, these professionals contribute meaningfully to quality of life outcomes. The evidence base supporting allied health contributions to dementia care has never been stronger, providing confident foundation for clinical practice while acknowledging persistent uncertainties that warrant ongoing inquiry and professional humility. Thank you for your attention and commitment to improving the lives of persons living with dementia and their caregivers. The knowledge and skills you gain from this course will directly impact the quality of care you provide and the outcomes your patients achieve. We will now review the exam questions to solidify your understanding. This review covers key concepts from the Dementia Rehabilitation and Management Evidence-Based Update course. For each question, I will read the question aloud, provide the correct answer, and explain the rationale. Question 1. According to the evidence presented in the course, what exercise parameters demonstrate the largest effect sizes for persons with moderate stage dementia? The correct answer is B. 30-minute or shorter sessions, 4 to 5 times per week. Rationale. A 2024 meta-analysis examining physical exercise effects on activities of daily living in persons with Alzheimer's disease found that higher frequency with shorter duration produced superior outcomes. Specifically, programs involving 4 to 5 sessions per week, with individual sessions lasting 30 minutes or less, demonstrated the largest effect sizes for persons with moderate dementia. This finding aligns with our clinical understanding that individuals in moderate stages often have reduced attention spans and limited exercise tolerance. Breaking exercise into smaller, more frequent doses allows for better engagement, reduces fatigue-related frustration, and optimizes the cumulative benefits of regular physical activity without overtaxing cognitive or physical capacity. Question 2. What is the primary focus of intervention goals for persons in the advanced stage of dementia? The correct answer is C. Comfort, quality of life, and palliative principles. Rationale. Advanced stage dementia represents a profound level of cognitive impairment characterized by minimal to absent verbal communication, complete dependence in all activities of daily living, and frequently co-occurring motor impairments such as rigidity and difficulty swallowing. At this stage, the goals of rehabilitation shift fundamentally from restoration or maintenance of function toward ensuring dignity, comfort, and quality of remaining life. Palliative principles guide care, focusing on symptom management, prevention of complications such as pressure injuries and contractures, gentle sensory stimulation, and support for family members. While active rehabilitation has limited applicability, therapeutic touch, positioning interventions, and passive range of motion remain valuable for maintaining comfort and preventing secondary complications. Question 3. What does the I in the DICE framework for addressing behavioral symptoms of dementia represent? The correct answer is B. Investigate. Rationale. The DICE framework provides clinicians with a systematic, evidence-based approach to understanding and managing behavioral and psychological symptoms of dementia. The acronym stands for Describe, Investigate, Create, and Evaluate. The investigate step is critical because it moves clinicians beyond reflexively attributing all challenging behaviors to the dementia process itself. During investigation, the interdisciplinary team explores underlying causes that may be contributing to the behavior. These causes span multiple domains, including physical factors such as pain, infection, constipation, dehydration, or medication side effects. Psychological needs such as boredom, loneliness, fear, or unmet emotional needs must also be considered. Environmental triggers, including overstimulation, understimulation, unfamiliar surroundings, or confusing layouts, are examined. Finally, caregiver factors such as communication style or rushed interactions may play a role. This thorough investigation ensures that potentially modifiable factors are identified and addressed before implementing interventions. Question 4. According to an umbrella review of non-pharmacological interventions cited in the course, which intervention ranked highest for reducing agitation in persons with dementia? The correct answer is D. Massage and touch therapy. Rationale. An umbrella review synthesizing evidence across multiple systematic reviews examined which non-pharmacological interventions demonstrated the strongest effects for specific behavioral symptoms. For agitation specifically, massage and touch therapy ranked highest among the interventions evaluated. This finding reflects the powerful role of appropriate physical contact in providing comfort, reducing anxiety, and meeting fundamental human needs for connection that may be difficult for persons with dementia to express verbally. Massage and touch interventions can include hand massage, gentle back rubs, or simply holding hands. These approaches address agitation at a sensory and relational level, offering reassurance and calm without the adverse effects associated with pharmacological management. While music therapy demonstrated effectiveness across multiple symptom domains, massage and touch therapy emerged as particularly potent for agitation reduction specifically. Question 5. According to systematic reviews presented in the course, what is the most frequently cited barrier to implementing evidence based dementia care? The correct answer is A. Staffing constraints. Rationale. Despite robust evidence supporting person centered care approaches and non pharmacological interventions for dementia, implementation in real world settings faces significant challenges. Systematic reviews consistently identify staffing constraints as the most frequently cited barrier. Inadequate staff to resident ratios in long term care settings directly limit the time available for person centered interactions, individualized activity programming, and non pharmacological approaches to managing behavioral symptoms. When staff members are stretched thin, they often default to task oriented care focused on essential physical needs rather than holistic approaches addressing psychological and social well being. Furthermore, high staff turnover rates in many care settings disrupt continuity of relationships, waste investments in dementia specific training, and undermine the consistent, familiar interactions that benefit persons with dementia. Addressing this barrier requires systemic changes in how dementia care is staffed and funded. Question 6. Which cognitive assessment tool demonstrates greater sensitivity for detecting mild cognitive impairment compared to the mini mental state examination? The correct answer is C. Montreal Cognitive Assessment, commonly known as the MOCA. Rationale. The Montreal Cognitive Assessment was specifically designed to address the ceiling effect limitations of the mini mental state examination in detecting early cognitive changes. The MOCA includes more challenging items and assesses additional cognitive domains, including executive function, which is often affected early in the disease process. Research demonstrates that the MOCA has greater sensitivity for identifying mild cognitive impairment, making it the preferred instrument when screening for early stage cognitive decline or when attempting to distinguish between normal aging and pathological cognitive changes. However, clinicians should be aware that both instruments exhibit floor effects in advanced dementia, meaning they lose their ability to discriminate between levels of impairment once cognition declines substantially. For tracking change in later disease stages, alternative assessment approaches may be needed. Question 7. According to the 2023 Global Delphi Consensus, which outcome measure is recommended for assessing functional ability in rehabilitation settings for dementia populations? The correct answer is A, the FIM motor subscale. Rationale. The functional independence measure is a widely used assessment tool in rehabilitation settings. However, when working with dementia populations, the 2023 Global Delphi Consensus provides important guidance on how to apply this measure appropriately. The consensus recommends using the FIM motor subscale rather than total FIM scores that combine motor and cognitive subscales. This recommendation stems from evidence that the cognitive subscale items may systematically underestimate functional improvement in persons with dementia. Individuals may demonstrate meaningful gains in motor function and physical independence while cognitive subscale scores remain suppressed due to underlying dementia. Using total FIM scores in these cases could mask genuine rehabilitation progress. By focusing on the motor subscale, rehabilitation teams can more accurately capture and document functional improvements in mobility, self-care, and physical independence that are achievable even in the presence of cognitive impairment. Question 8. According to the World Guidelines for Falls Prevention and Management, which approach should be avoided for fall prevention in persons with dementia? The correct answer is C. Physical restraints. Rationale. The World Guidelines for Falls Prevention and Management explicitly discourage the use of physical restraints for fall prevention in persons with dementia. This recommendation is based on substantial evidence demonstrating that restraints actually increase rather than decrease injury risk. Restrained individuals may struggle against restraints, leading to strangulation, falls when attempting to escape, or injuries from prolonged immobilization. Beyond physical harms, restraints produce significant adverse psychological effects, including increased agitation, fear, loss of dignity, and accelerated functional decline from immobility. Evidence-based alternatives for fall prevention in dementia populations include exercise programs incorporating balance and strength training, environmental modifications such as improved lighting and removal of hazards, careful medication review to identify agents contributing to fall risk, and appropriate assistive devices. These approaches address fall risk while preserving mobility, autonomy, and quality of life. Question 9. What is the evidence-based approach to wandering management that balances safety with quality of life? The correct answer is D. Environmental modifications creating safe wandering paths. Rationale. Wandering is a common behavior in dementia that presents safety concerns while also reflecting fundamental human needs for movement and exploration. Evidence-based approaches recognize that the goal should be safe wandering rather than preventing wandering altogether. Environmental modifications creating safe wandering paths allow individuals to move freely while minimizing risks. These paths may be designed as continuous loops that naturally return the person to familiar areas, incorporate visual cues and appropriate lighting, and are free of hazards. Complementary strategies include structured daily routines that reduce restlessness, investigation of underlying needs that may drive wandering behavior, such as searching for something familiar or attempting to fulfill a remembered role, and technology solutions such as GPS tracking devices and door alarms that provide detection and notification capabilities. Complete restriction of movement through locked units or physical means constitutes restraint and carries documented harms including increased agitation, loss of function, and diminished quality of life. Question 10. When providing dementia care to culturally and linguistically diverse populations, which practice is recommended for clinical encounters? The correct answer is B. Using professional interpreter services. Rationale. Effective dementia care for culturally and linguistically diverse populations requires clear, accurate communication that respects cultural context. Professional interpreter services are essential for meeting this standard. While using family members as interpreters may seem convenient and comfortable, this practice raises significant concerns. Family members may lack medical terminology knowledge, may filter or modify information based on their own beliefs about what the person should know, and their dual role compromises confidentiality and professional boundaries. Children should never be placed in the role of interpreter for their parents or grandparents in clinical situations. Professional interpreters provide accurate language translation and can serve as cultural brokers, helping clinical teams understand cultural beliefs about dementia, aging, family roles, and healthcare that may influence care preferences and treatment adherence. This cultural brokering function enables teams to communicate in culturally appropriate ways, building trust and improving care outcomes for diverse populations. This concludes our exam review for the Dementia Rehabilitation and Management Evidence-Based Update course. Remember that these concepts reflect current best practices in evidence-based dementia care, emphasizing person-centered approaches, non-pharmacological interventions as first-line treatments for behavioral symptoms, and maintaining quality of life across all stages of the disease process.